Thomas is there. Nazar, President.
Oh, Thomas is there. Welcome.
Thomas is there. He told he
Yes,
wanted
sir.
to join.
Yes, sir, we can start. It's
Dr. Joe,
Giri.
Dr. Joe, please check your audio before starting. Dr. Joe,
Giri.
can you hear me, Dr. Joe? Joe
7
Chiriyat?
o'clock.
Yeah, we are starting.
Yes, I can. Can you hear me?
Okay.
Dr. Joy is fine.
Vinil?
Yeah.
Can you hear
Now
me?
it's okay. Yeah, it's okay. Now it's
Yeah.
okay.
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 Yeah. Hello.
Sir, then we can start, sir. Then we can start now. It's 7 o'clock now.
Yes. Good evening, respected teachers, senior
Good evening.
and officials of the ISA Kerala State Chapter. I request Dr. Venkatagiri, President-elect ISA National, for a brief introduction. Over to Giri, please. Dr. Giri, please.
Yeah. Good evening, all. President Dr. Nazar, Secretary Dr. Binil, our faculties Dr. Sunil Pandya and Dr. Joe, then our chairperson Dr. Madhusudan and Gopakumar, senior members, faculty members, past presents and participants. Good evening to you all. It is the 12th in the series of our webinar, and a long time we thought that we should have one on obstetrics, and the name which came to us first was none other than Dr. Sunil Pandya. I talked with him around 2 months back. That time he was busy with some other one. He told that he was. Then we had the PG webinars and all we could not make. So we thought the first should be on obstetric, and now we are for the obstetrics. And we have Dr. Sunil Pandya, who will be introduced by Madhusudan. He knows him more than me. And he will be authority on obstetric anesthesia and giving the talk on that. And other person may not be known to all, and a good faculty from our own state, Dr. Joe, he will be talking on obstetric analgesia. So with this brief, I request President for his opening remarks and welcome on and further proceed for the meeting.
Thank you, Dr. Giri. Respected President-elect ISA National, Dr. Venkatagiri. Dr. Meenakshi Sundar, our honorable faculty, Dr. Sunil S. Pandya, Dr. Joe Chiriyat, Dr. Madhusudan and Dr. Gopakumar, our honorable secretary, Dr. Vinil. Good evening and welcome to this 12th webinar of ISA Kerala State Academic Program. We were organizing regular meetings and webinars, and that was very well appreciated from all over the country. And many of us have given feedback that it has been with the postgraduates and the students. That's why we thought of creating the webinar, and we thought of having it in a great academic standards that we were able to make it. And that shows the response from our fellow members. There is a good response over YouTube and over Zoom meetings. Before starting my video background, I take this opportunity to welcome you all to the Kerala State webinar to be held on November 1st. There's an opportunity for all the postgraduate and consultants to have an interaction with the well-known faculties. We are trying to have some overseas faculties. This opportunity to welcome you all to this on November 1st to our webinar Kerala State. Let me come to my duty. In today's topic, as Dr. Giri said, it's on obstetric anesthesia and obstetric intensive care. We have a national level faculty, Dr. S. Pandya, the Director Consultant Obstetric Care, Century Super Specialty Hospital, and Chief of Anesthesia and SICU AIG Hospital, Hyderabad. He is a well-known faculty among anesthesiologists, obstetrician, and a regular well-reputed speaker on the subject of obstetric intensive care needs. Sir, I'm really happy and honored to welcome you to to the state of Kerala. And I extend you a warm welcome on my own personal behalf and on behalf of ISA Kerala State Chapter. Dr. Sunil Pandya, welcome you, sir. And it is talking about navigating safety. And I am really sure that that is enriched by the knowledge he's acquired from his long-term practice of this specialty. Our second topic is on labor analgesia, its recent advances. We have Dr. Joe John Cheriath, our own member, who is the Associate Professor of Anesthesia, Amela Medical College, Thrissur. Sir, I am really happy to welcome you to this meeting and happy to know from you on this very recent topic with its recent advances. Dr. Joe John Cheriath, welcome you to this meeting. We have two eminent persons to share these sessions, two academicians, and
Thank
one
you.
is Dr. Madhusudhan Upadhyaya, who is the professor and former HOD of KMC Mangalore, who was with us for most of the meetings. And he really made us, all our meetings, very interactive and very useful. Dr. Madhusudhan Upadhyaya, I'm happy to welcome you to this meeting on behalf of ISA Kerala State Chapter. We have Dr. Gopakumar, who is a senior consultant at Anantapuri Hospital Research Institute, Tirunelveli, an active member of our own state branch, who is also sharing this session with Dr. Madhusudhan Upadhyaya. Sir, I extend you a warm welcome to this meeting. I take this opportunity to welcome Dr. Venkatagiri, who is, I can say, the soul of this whole organizing webinars. His ideas and his relationship with all the faculties has made this very successful and very useful and really popular. Dr. Giri, I'm happy to welcome you.
Thank you. Thank you.
Dr. Vinil, the man behind the implementation of these ideas, the man who has done a lot of things to make this webinar, trying hard to make it the best possible way. Vinil, welcome you to this meeting.
Thank you, sir. Thank you.
I take this opportunity to welcome our senior leader, Dr. Meenakshi Sundar, and other senior faculty members. And on behalf of ISA Kerala State Chapter, I take this opportunity to welcome all our respected delegates. I'm sure that there will be some participation from other specialties, some obstetrics, and I'm happy to welcome all my obstetrics friends to this meeting. Once again, I welcome you all. And I request Dr. Madhusudhan Upadhyaya to start the academic session. Over to Dr. Madhusudhan Upadhyaya. Sir, please.
Thank you very much. Dr. Nazar. As you said, I have been associated with the ISA Kerala activities since quite some time now. And I'm happy to be a part of it because it's all academics and it's really nice to be a part of it. And the first lecture of the evening would be by Dr. Sunil Pandya. And as Venkatagiri said, Sunil Pandya has been quite close to me, a friend and a guide in most of the aspects of obstetric anesthesia. And he doesn't require any introduction, I am pretty sure. Just to complete the formalities, he is Director Consultant Obstetric Critical Care in Century Super Specialty Hospitals. And he is also a Chief of Anesthesia and SICU in AAG Hospital, Hyderabad. More importantly, Sunil Pandya has been a guest adjunct faculty for KMC Mangalore, and we have been benefited by his knowledge and expertise. I think Sunil is one of the best in the business right now in when you talk about obstetric anesthesia and critical care. And I'm not talking about obstetric critical care. He's master in critical care itself. And he also holds a PDCC in critical care. Therefore, he's up there when it comes to the general critical care too. And as is said, we can't find a better personality than Sunil Pandya to talk on obstetric anesthesia right now in our part of the country. Today he will talk about acute maternal collapse, navigating safely. And again, as I said, we can't find somebody better than him to talk about this topic too. And next, when Joe comes, we will introduce him later. Sunil, as anybody who has come into contact with him, you would realize that he's not only an extraordinary teacher, he is a wonderful person. Therefore, learning from him is an experience. We all are teachers, but I think Sunil is a much better teacher. I think we'll listen to him. I will not take much of your time because there will be a lot of things to discuss at the end. And over to Dr. Sunil Pandya.
Thank you, Dr. Madhusudan Upadhyay, for the kind words and elaborate introduction. Thank you again. I would like to thank Dr. Venkat Giri, the President-elect National ISA, Dr. Nazar, President of ISA Kerala branch, Dr. Bill Matthews, Honorary Secretary of ISA Kerala, and other office bearers of ISA Kerala City branch for inviting me for this webinar on obstetrics, critical care obstetrics and obstetric analgesia. Is my screen visible to all?
No, sir, it does not come. Now it's coming.
No, you're done.
Yeah.
It's fine.
Okay. So again, thank you very much for this opportunity. So next about 30-35 minutes, I shall be talking on this topic of acute maternal collapse. How do we navigate safely from this crisis? Greetings from Association of Obstetric Anesthesiologists India. Greetings from Fernandez Hospital. Fernandez Hospital, just to give a brief introduction about the hospital where our team is working. It's a 320-bed tertiary care perinatal center with an annual delivery rate about 9,500. We have started the first OB critical care unit in 1997 with 2 beds, and now it's about 6 bed with 18-bed high dependency unit and a step-down unit. Good support from the neonatal intensive care, the fetal medicine unit, and of course, we have a dedicated obstetric medicine unit also, so that a physician, critical care, anesthesia, and neonatologist all together, we give input in managing a critically ill parts unit. We have in-house critical care outreach team, and of course, putting in place the early obstetric warning systems and saving mothers course system, which is our own, I would say, invention and implementation. In addition to critical care, we also practice on-demand obstetric epidural analgesia 24/7, and to date, we have more than 1 lakh of obstetric epidurals. We also run academic training programs, fellowships in OB anesthesia and PhD programs in anesthesia. As a team, we cover 10 hospitals, but this is another hospital where we have level 4 obstetric critical care unit with advanced life support system like ECMO, IABP, and interventions, which about 10% of critically ill parents, they need these radiological interventions or cardiological interventions. Nil conflict of interest. The photographs shown in my presentation have been obtained with the patient's consent. So anybody using this presentation, please delete those photographs. Coming to acute maternal collapse. It's a rare event, fortunately, but it's life-threatening and has a wide-ranging etiology. The maternal and the neonatal outcome of the acute collapse primarily depends on the timely pickup, prompt assessment, effective cardiocerebral resuscitation. I go beyond CCR, I go cardiocerebral and splanchnic resuscitation, because at the end of the day, we need to initiate aggressive multi-organ supportive strategies. And effective resuscitation involves prompt delivery, which often includes perimortem cesarean section or resuscitative hysterotomy, a transfer to OT for the same, for a double setup, or a cath lab transfer for embolectomy, or a percutaneous coronary intervention, or intensive care unit transfer. Well, how do we define maternal collapse? Maternal collapse is an acute event that involves cardiovascular system, collapse of cardiovascular system, collapse of respiratory system, imminent respiratory failure, resulting in cerebral hypoxia, resulting in reduced level of consciousness, or almost imminent death or potential death if you don't intervene at the right moment. And it can occur at any stage in pregnancy up to 6 weeks after delivery. That's in the puerperal period also. If you look at the maternal mortality review, like Embrace is nothing but mother and baby risk reducing audit and confidential inquiries of the UK 2019 data. We pretty well know the cause of maternal mortality. Sepsis is still the direct leading cause, and cardiac cases are the leading cause of maternal death. But importantly, even in our own country, if you look at the maternal mortality, hypertensive disorders in pregnancy are the leading cause of maternal mortality. About a couple of years back, it was hemorrhage that was the leading cause, but now hypertensive disorders in pregnancy are the leading cause, followed by hemorrhage, followed by sepsis. But nobody talks of near misses or the collapse data. We don't have the near miss data in all these mortality reviews, and the incidence is often unknown. But when we did audit of our own hospital and our own data from hospital and different reviews from across the world, the near miss data in obstetric is almost about 8 per 1,000 deliveries. That means out of every 1,000 deliveries, we have 8 imminent or potential deaths, which can result in mortality if you don't give right treatment, which if you look at, the ratio is quite high. But because if you look at even in the most developed state like Kerala, the mortality, maternal mortality is about 40 to 45 per 1 lakh live birth. In state of Telangana, it is about 70, they say, but it's around 90 to 100. But if you look at the pan-India maternal mortality rate, it's around 150 to 200 per 1 lakh childbirth, living childbirth. And if you look at the near miss data, is almost 8 per 1,000. So it's very, very high. Why are pregnant women at risk of collapse? Well, often they are unanticipated. Again, because of the increased physiological reserve, the plasma volume expansion happens almost to the tune of 50%. So they don't have the classic telltale signs, and they often have a late and dramatic presentation. I have seen mothers who talk to you comfortably, who smile at you, and within next few minutes, they are drop dead. So they are very, very deceptive in nature. And often, most of the deliveries, like 80% of deliveries that happen in our country, they happen either in dedicated obstetric center like government hospital or private nursing homes, which don't have multidisciplinary team backup. Very few hospitals, like we have plenty of corporate hospitals, but very few corporate hospitals have a very excellent dedicated setup, OB setup. Like even at Fernandez Hospital, which is a excellent tertiary care OB center, to get multidisciplinary support, it takes time because we don't have in-house cardiologists, nephrologists, neurologists, or any of those hematologists, which often this patient they require. So if you don't have multidisciplinary team, often it is difficult to give a comprehensive care to this patient who are collapsing suddenly, who require any of these interventions and consultations. Often underestimation of severity of lesion, like many a times, as I said, I'll be discussing a few cases. We don't underestimate we often underestimate the severity of lesion, and we take the things for granted. Suddenly, they present with sudden mortality, often very, very shocking. And many a times, because of several reasons, the third delay is, or second delay is lack of proper monitoring, lack of proper transport, and often the sick patient, they reach late to the referral centers, and the proper monitoring and planning doesn't happen, and it leads to morbidity and sometimes mortality also. So we have a missed window for early evaluation, early aggressive medical interventions, and multidisciplinary team approach because of these various reasons. I don't want to go into the details of impact of physiological changes, but in a nutshell, parturients, they breathe more, they pump more, they clot more. It's a virtual clotting machine. So they are very prone for thrombotic and thromboembolic events. The cardiac output is increased almost about 30 to 40%. And so basically the heart is stressed out. The cardiovascular system is stressed out. So any patient who has underlying cardiac disease, they present during pregnancy. And if the patient has severe lesion, they present around 16 weeks of pregnancy where the first peak in cardiac output occurs. If they have moderate lesion like mild, moderate to severe mitral stenosis, they present around 28 to 32 weeks of gestation where the second peak in cardiac output occurs. And quite often, if the mother has mild to moderate cardiac disease, they often present at the time of labor and delivery, where the peak increase in cardiac output happens. Almost it increases by 50%, and the mother can go into congestive cardiac failure. So they pump more is a very important thing. Clotting also, as I said, because of the increased procoagulation system, it's a nature's control over minimizing blood loss at delivery. So many times, especially in the current COVID pandemic, which is prothrombotic state, pregnancy, again, it enhances the clotting event. I will be coming a few cases about COVID-19 as well. So, but to our fortune, they have excellent fighting capacity. If you give right intervention at right time, they bounce back very rapidly. So as a obstetric clinician or an obstetric physician, anesthesiologist, or intensivist, whatever you call, we need to know what is the physiological change, and when the physiological change becomes pathological, we need to have an eye to pick up that pathological change, and when it becomes ominous. So physiological versus pathological versus ominous, it comes with experience, it comes with knowledge, it comes with wisdom. And many times we need to have this early warning score systems in our hospital. Like you have modified early warning chart, which is there, which was first published by National Health NHS in the UK way back in 2008, and we modified to our needs. But just about 5 years back, we invented our own score, Saving Mother score at our hospital. And my colleague Dr. Kausalya has done a PhD on this research on this topic. And we found that SMS score is a very, very good tool because it not only takes into account the physiological variables of the patient, but also takes into account the clinical variables and laboratory parameters, which gives us a comprehensive assessment and predicts the maternal mortality. In addition, the easiest way to pick up a sick mother, especially mother with infection, is QSOFA, or the quick SOFA. Quick SOFA, again in pregnancy, is a little subtle modification is there, and we call it the maternal QSOFA, where we take into account 3 parameters: the systolic blood pressure, the respiratory rate, and the altered mentation. Any of this, the score is more than 1, the risk of morbidity and mortality is high. But bottom line is all these risk factors, risk assessment, early warning systems will be in place, but it is just the experience, knowledge, evidence, wisdom, and the team concept is what is important. When you look at the cause of mental collapse, it is from head to toe. It could be intracranial cerebral hemorrhage or stroke, ischemic strokes, eclampsia causing generalized tonic and clonic seizure, including status epilepticus, or pulmonary embolism, memory embolism, so on and so forth. Several causes are there. If you look at the system wise from head to toe, head like eclampsia, epilepsy, cerebral vascular accident, vasovagal response, and coming to cardiovascular system, which is the direct leading cause of mental mortality, myocardial infarctions. Yes, myocardial infarctions, especially advanced maternal age, multifetal pregnancies are increasing in our country. And even the atherosclerosis, atheromas also seen. Aortic dissections are quite common, especially patients with Marfan syndrome. And you need to keep this in mind. Hypoxia because of asthma, embolism, pulmonary edema, and anaphylaxis. Hemorrhage, as I said earlier, and whole body, which includes hypoglycemia, fortunately, is rare, but unless the patient has a pulmonary and hepatic failure because of multiple etiologies or any of these causes, any of these things which have been mentioned. So basically, if we can, whenever we have a collapsed patient, it is easy to remember the causes in the terms of acronym ABCDE, UPS, or 5H and 4 Ps, which have been there in as a part of BCLS algorithm. But this ABCD UPS is what we developed algorithm in our hospital. A includes anaphylaxis, anesthetic causes. B is bleeding, bleeds in brain, bleeds in liver, like hepatic rupture, quite common in HELLP syndrome and AFLPs. Cardiac causes, drug causes, magnesium, oxytocin, or any of those local anesthetic, systemic toxicity can come under anesthetic causes also. Eclampsia, embolism. Eclampsia includes all hypertensive spectrum. Embolism, commonest is of course pulmonary embolism followed by amniotic fluid embolism, and air embolism is not uncommon. Uterine causes like abruptio, cubular uterus, inversion of uterus, which can cause not only bleeding but also vasovagal and neurogenic shock. Pulmonary causes like ARDS, pulmonary edema, placental causes, adherent placenta, retained placentas, and arteriovenous malformation in the uterine cavity, and COVID-19, swine flus, and sepsis, so on and so forth. We have defined these causes in our own article that was published in IJ a couple of years ago. There is another acronym for remembering or evaluating perioperative or peripartum cardiac arrest or collapse in pregnancy, like BioCHOPS. More or less all the causes have been discussed. So coming, one of the commonest causes, hemorrhage. Yes, hemorrhage can be of multiple origin, like antepartum hemorrhage, intrapartum hemorrhage, postpartum hemorrhage. Of course, atonic hemorrhage is the most common. It is commonly as it is known as 4 T's: tone, tissue, trauma, and thrombus. And quite often in pregnancy, the blood loss is estimated to the tune of 40% and above. I'll just take you through this case, which we had a couple of years ago. A second gravida, Paravan Lyman, 36 weeks, presented with severe preeclampsia with intrauterine fetal demise. There was no abruption on ultrasound. She's deeply jaundiced with encephalopathy. Hemoglobin is good. That is generally we don't see the hemoglobin in Indian parturients. So this indicates like hemoconcentrated state. Thrombocytopenia, TLC is almost 47,000. Element of sepsis is there. LDH is in thousands. Elevated AST, ALT, INR is elevated. Fibrinogen is very low. Again, this is a hallmark of postpartum hemorrhage and severely acidotic. If you see pH 7.1, PaCO2 of 11, and base deficit of -18, Apache 2 score at admission was 26, SOFA score, sequential organ function assessment score was 12, and acute kidney injury, hypoglycemia, hyperammonemia. So if you look at this is jaundice patient, acute hepatic failure, IUD, is it a pregnancy-related jaundice or a coincidental jaundice? We don't know, or multifactorial jaundice, we don't know. So basically, our working diagnosis was severe preeclampsia with HELP, AFLP, with sepsis and infective etiology like hepatitis A or E, which is quite common. And generally, we did a preeclampsia profile in addition lipase and amylase because pancreatitis is quite common in this setup and with this background. And we also send IgM antibodies for hepatitis A, hepatitis E, leptospira, and malarial parasites. In addition, blood cultures, urine cultures, and procalcitonin. So whenever you have a sick parturient, have a low threshold to evaluate. Don't send investigation in part. Investigation hit bang across so that you can give correct treatment. Suppose if it is a sepsis jaundice, you can straight away go for higher antibiotic. If it's a malarial parasite, if you don't evaluate, you go and give, but you don't give antimalarial. So it is always better to give investigate. Especially leptospirosis is very, very common, especially post rainy season, post monsoon. And we know that tetracyclines and erythromic macrolides, they work very well against these antibiotics, penicillins also. So evaluate, have a low threshold to evaluate this patient properly. We started correcting the coagulopathy, gave magnesium sulfate because of underlying hypertension. Patient was oliguric acid, creatinine was 2.3. We started put in central line, art line, and connected to cardiac output monitor. Targeted resuscitation was started. Tranexamic acid was given, and we did an elective emergency low cesarean section, low transverse incision under general anesthesia. She was having good attempts at the end. Would you like to extubate this patient? But as I said, with pH of 7.1, I would not dare to extubate this patient. So we electively ventilated. Fortunately, with targeted resuscitation, kidneys opened up. As I said earlier, it was hemoconcentration. So with hydration and volume resuscitation, and with sepsis bundled approach, she opened up the kidneys and electively ventilated. Targeted organ supports continued. Vitamin K was given because of jaundice. And on the first post-op day, drains was 2.6 liters. It was sanguineous. Coagulopathy was being corrected, and on the first until first POD, that is about 24 hours, we had transfused 46 units of blood. But because of the increased drain, we took her up for return to OT was done. Re-expiration was carried out, and during re-expiration, what was the plan? The surgical wound was opened. It was a transverse incision. It was difficult to assess. The clots were removed. Almost 4 liters of clots were there. Aggressively, coagulopathy was corrected. Calcium also was supplemented depending on the blood gases. Tranexamic acid, vitamin K were continued. Despite that, patient had diffuse ooze. So, and the omentum had become like a pancake. So, omentectomy was done, and 2 drains were left in C2 whiteboard drains, one in the post-operable, one in the paracolic gutter, and patient was shifted back to ICU and extubated next day. Ambulated, sips of water were started, coagulation targets were well maintained. Unfortunately, on Sunday morning, patient started bleeding again. And it took almost 11 hours for the surgeon to take a call. And we had to literally force the patient because the drains were 3 liters of blood in the drain. And despite good, decent coagulation factors. So the surgeons were asking us to give recombinant factor 7A, but I thought probably because 3 liters is something surgical bleed, we cannot rule out. And we had to take her up for re-expiration. And we know that recombinant factor 7A does work. In fact, we had about 16 cases usage. But when you have a surgical bleed, it doesn't help. And we wanted to rule out any surgical cause because of the jaundice and probable AFLP hypoglycemia in the initial setting. Hepatic rupture is one thing which was a possibility. So we took her up inside. And if you look at the hemoglobin in the drain was 8 grams and the hemoglobin in the patient plasma blood was about 4.7 grams. So this was indicated that we took her up to re-expiration. And fortunately, the liver was good. There was no, we had to take a inverted T incision. Uterus was well retracted. There was no suture bleed. And we did a requested surgeon to do bilateral internal ligation and components are replaced. Totally, she received 122 units of blood over 3 days. She developed TALI, she developed ARDS, but on the 5th day, she was extubated. If you look at the tally of the blood and blood components, right from packed cells to FFPs to RDPs, SDPs, cryos, she received virtually every component. And totally over a period of 4 days, she received 122 units. But fortunately, on the 5th day, she was extubated and she went home. And if you look at the blood gas, she came with a pH of 7.1, 7.1. But fortunately, within 24 hours, she remained at pH of 7.4 all throughout. That means aggressive ongoing resuscitation was done. We started with piperacillin tazobactam, later on was converted to meropenem. The point I want to raise with this case is, well, whenever you have a patient with multi-organ dysfunction syndrome, jaundice, coagulopathy, please don't go for cosmetic incisions. Go for a midline incision. It is always better. And always, whenever there is permanent coagulopathy, it is better to do internal ligation prophylactically and a Behling sutures prophylactically, because we got avoided in this case re-explorations on 2 occasions and 122 units of blood transfusions. So the lesson, of course, we have done this several earlier, but again, new teams of surgeons, they come in and they always go in for cosmetic incisions. But whenever you have a patient with multi-organ dysfunction syndrome for emergency cesarean section, midline incision, prophylactic internal iliac ligation, and compression Behling sutures have to be taken. So whatever causes of postpartum hemorrhage can be minimized. So a major obstetric hemorrhage is one of the commonest cause of collapse. And whenever you have peripartum hemorrhage, massive transfusion protocols, the PRBCs, FFPs, platelets ratio has to be 1:1:1:1. Appropriate triggers, don't allow the hemoglobin to drop to less than 6 grams. Critical hemoglobin is 4.5 grams, but the transfusion trigger should be 6.5 grams and above. And whenever the patient receives more than 4 FFPs, 4 units of packed cells, always go for FFPs and random platelets also. Again, giving platelet transfusion in an Rh negative woman is going to be a little dicey, because you may sensitize if she wants to conceive again in future. So whenever you're giving random platelets or pooled platelets in an Rh negative woman, see that she receives anti-D, or you do a clear Bedke test to look at the isoimmunization. But it is always better to give a dose of anti-D. FFPs early should be used. Check for plasma fibrinogen. As I said, plasma fibrinogen is one of the earliest indicator to predict postpartum hemorrhage. So whenever the plasma fibrinogen is less than 200, the onset of the incidence of PPH is quite high. So our target should be more than 220 milligrams, because we know pregnancy, the plasma fibrinogen is almost about 350 to 450 milligrams per deciliter. And appropriate monitoring during massive transfusion, like lethal triad of coagulopathy, hypothermia, and the warming devices, all those things have to be taken care of. Very, very important. And again, as I said, targeted resuscitation, targeted. So have a low threshold to use advanced cardiac output monitoring devices. One of the secondest commonest cause of mental collapse is hypertensive disorders. Hypertension, again, is a wide spectrum, right from preeclampsia to preeclampsia with severe features to HELLP syndrome, eclampsia with status eclampsia. Acute fatty liver pregnancy also is considered as a part of preeclampsia. And also at the other end of the spectrum, you have hypertensive cardiomyopathy with congestive cardiac failure. And often it can cause multi-organ dysfunction syndrome because of HELLP, is a MODS, AFLP, MODS, pancreatitis is quite common. And fortunately, if you look at the cause of maternal mortality in hypertensive disorders, the causes of maternal mortality because of pulmonary edema is virtually zero. If you see from 2000 onwards, it is 0, 0, and 0. And that is because anesthesiologists have invaded the labor rooms, and any patient with simple pulmonary edema, just putting off non-invasive ventilation, CPAP, BiPAP, it's excellent, and it resolves very, very easily, unless the patient goes in subsequently for ARDS, which requires invasive ventilation. But non-invasive ventilation is not a contraindication in pregnancy. Yes, you need to have a rigid protocol to minimize risk of aspiration. But if you look at the causes of mortality in hypertensive disorders, it is intracranial event, like in the cerebral event, like subretinal hemorrhage, intercerebral hemorrhage, bleeds are very common, quite common. Hepatic ruptures are common, especially with underlying HELLP and AFLPs, and necrosis of liver parenchyma, and there have been few cases where patient ended up with liver transplantation also. Pulmonary edema and risk is very high because of the oncotic pressure. If you look at the oncotic pressure, pregnancy is a low oncotic pressure state. And whenever the peak reduction in oncotic pressure happens in the postpartum period, 48 to 72 hours after postpartum period. So whenever the mother is hypertensive, develop hypertensive crisis, they go into pulmonary edema very, very easily. You have to be cautious about handling a parturition with chronic hypertension superimposed preeclampsia. So patients who are chronically hypertensive, that is, if the onset of hypertension is beyond earlier than 20 weeks of gestation or essential hypertension, the concentric LVH occurs quite early in during pregnancy. And because of concentric LVH that happens during pregnancy, the left ventricular end-diastolic pressure is high, the compliance of the left ventricle is low, and whenever the afterload increases, the ventricle fails easily. And in addition, with elevated LVEDP, reduction in choroid oncotic pressure, it leads to a cocktail of low oncotic pressure state, and the glycocalyx structure of pulmonary interstitium also is disrupted, leading to acute pulmonary edema. So you have to be careful. And I must tell you that even with this ghastly looking pulmonary edemas, where the entire tube is flooded with blood, they recover very fast with proper position, invasive ventilation, judicious PEEP, and elective good ventilative strategies. They recover quite fast. It is very, very important. Again, I have a low threshold to go for advanced monitoring devices because if the extravascular lung volume is more than 15 ml per kg, the risk of pulmonary edema is refractory pulmonary edema is high, and they have a high maternal mortality. Importantly, whenever you have antepartum pulmonary edema or ARDS causing maternal hypoxemia, you have to remember that fetal demise is quite common, it's quite imminent, because the fetus lives on the steep portion of oxygen dissociation curve. So even minor changes in maternal PO2 can cause acute fetal hypoxemia and fetal demise. So whenever you have, like especially in COVID pandemic or swine flu, whenever you have PF ratios of less than 200 or 250, it is always good to maintain PF ratio of more than 250 to 300 in pregnancy whenever you are ventilating the patient, because if the PF ratios are persistently low, that means this patient may require prone ventilation or termination. Because if the pregnancy duration or the pregnancy or gestation age is beyond 24 weeks, persistent hypoxemia despite optimal PEEP, terminate the pregnancy. Actually, you can salvage the fetus as well as improve the pulmonary dynamics in the mother. The next common cause of acute collapse is sepsis. Again, sepsis is a conundrum. It's a disease of continuum. You have mild infections like simple vaginitis or chorea pneumonitis, which can progress to sepsis, severe sepsis, septic shock. As you go up the pyramid, the mortality increases almost 60%. So you need to categorize sepsis, especially mothers with PPROM or PROM of more than 12 hours to 18 hours duration. We know the sepsis bundles very well. The hour one bundle, 6 hour bundle, 24 hours bundle. I won't go into the detail. I can take more into questions, but more importantly, you need to remember that our first hour bundle includes prompt resuscitation, fluid resuscitation, taking cultures, measuring lactate, and importantly, resolving lactate is of paramount importance. And more importantly, source control. Source control is what is important. So if the source is chorea pneumonitis, terminate the pregnancy if you are not amenable, or if the return products of conception and there is a source in the pyometra is there, just do drainage is important. And we just have to follow the cerebral sepsis guidelines, which have been modified. The first guideline came in 2003, and the latest modification came a couple of months back, especially incorporating the COVID changes as well. So we all know in pregnancy, the different systems that are involved, all those physiological changes, they get exaggerated because of sepsis. And the cumulative effect of sepsis with physiological changes lead to sudden collapse, cardiovascular collapse, respiratory collapse, renal collapse, and coagulation, hypercoagulability causing microthrombi and DIC with prothrombotic events. We have sepsis score, SOS score, wherein sepsis and obstetric score, wherein they have different parameters like temperature, systolic blood pressure, heart rate, respiratory rate, SpO2, leukocyte, and immature neutrophils like band forms and lactates, and scoring system is done. But more importantly, what you need to remember is bang early, terminate the pregnancy early, and give appropriate antibiotic, give a wide spectrum antibiotic like start E. coli are quite common. So gram-negative sepsis is quite common. And generally we start off with piperacillin tazobactam or with metrogyl or meropenem with metrogyl, and always send procalcitonin blood cultures. As soon as the culture comes, you can always de-escalate the antibiotics. But rather than starting a cefotaxime or something which is a multi-drug resistant bug, most of them are multi-drug resistant bug. So you need to follow your antibiogram. You need to follow what antibiotics she has received. You need to follow which hospital she has come from. Is she carrying the bugs from other hospital? So rectal swab, nasal swab, MRSA, all those standard protocols have to be followed. Coming to SARS-CoV, this case report I picked up from Embrace 2019 mortality review of United Kingdom, where you see a woman in third trimester of pregnancy was admitted 1 week history of COVID-19 symptoms. She was in the ER for several hours and was assessed with having mild to moderate COVID-19 by the medical staff. She did not have any evidence of respiratory failure, but was hyperventilating. It is very important. She did not have evidence of respiratory failure, but was hyperventilating. But immediately within 24 hours, like within 12 hours, she deteriorated with a rate of 70, desaturated, and next day she died. This is how COVID-19 is. And we have seen several cases in our hospital, as Dr. Madhusudan Upadhyay rightly pointed out, his son, unfortunately, we wish him a speedy recovery, like SATs dropped to 90-92%. They are very, very normal and they're very deceptive, and suddenly they deteriorate and fulminate. And so we need to have a low threshold to do a CT scan of the chest and measure the CT severity score, and accordingly start non-invasive or invasive ventilator treatment, including phone ventilation. So SARS-CoV is very deceptive. In fact, initial reports of 22 cases from China in February, not a single mortality, but the subsequent report from Iran and US, Houston, Texas, they reported about 9 cases of maternal mortality. And the commonest cause was missing the severity early during the disease, and the CT scan was not done to assess the severity of score. So in pregnancy, you can do CT scan, if you feel the sensitivity is very high, if you feel the risk versus benefit, risk outweighs the benefit, if the benefit outweighs the risk. And importantly, you can also use lung ultrasound. Lung ultrasound can pick up B lines on the lung ultrasound easily. And this was another case. 3 women died at home because the SARS-CoV were home isolated, and they continued to stay at home, and they didn't follow the advice, and they lost the follow-up, and they died at home. And we all know that pregnancy is a prothrombotic state, a hypercoagulable state. And we also know that SARS-CoV-2, the incidence of microthrombi and the risk of thrombosis and embolism is very, very high. And every pregnant patient, despite low BMI, they should receive antepartum heparin as a prophylaxis, and include it should be continued at least for 1 week postpartum period. So do not take things for granted. Thrombosis, thromboembolism is quite high, and they need to cover perioperative heparin prophylaxis if it is not contraindicated. The next common cause of cardiovascular collapse is the cardiac causes. As I said, cardiovascular is a leading cause of maternal mortality. And remember that heart has a poor reserve vis-a-vis lungs in pregnancy. Again, I always go back, have a low threshold to invasively monitor. If you see NIBP, when the BP is extremes in nature, NIBP can be spuriously low, or maybe falsely elevated or false low. So you need to have a low threshold to put invasive monitoring facility. And have again a low threshold to go for a high-end cardiac output monitor, because they give us cardiac output monitoring. Again, these monitors are not hunky-dory, or they are not gospel truth. They don't give, but the trend of this parameters like stroke volume variation, stroke volume, cardiac index, CVO2, SVI, they help us in titrating inotropes, titrating vasopressors, titrating vasodilators. So you can optimize the preload, optimize the afterload, optimize contractility, optimize rate and rhythm. These are what the 5 things that we need to look at. If you look at the cause of maternal death because of cardiac causes, ischemic deaths again are the highest followed by valvular heart disease. Fortunately, in the West, VHDs are less, but in our country, valvular heart disease are still high. Again, cardiomyopathy is increasing in number. But more importantly, this is the chunk that is worrying. This is the data from the Embrace, the United Kingdom. The sudden arrhythmia and cardiac death, the morphologically normal heart. sudden arrhythmias causing death in a morphologically normal heart is 18%. So many a times, if the patient suddenly dies, we don't know, and the cardiologist may report echo is normal. So patient can still have underlying a prolonged QT interval or all these genetic arrhythmias, which we don't know. So you need to have a high degree of suspicion. So you need to probe into the family history of very well. Again, this was one of the commonest cause of maternal mortality in the West, aortic dissection. And this was a poster that has reduced the incidence of maternal death because of aortic dissection, especially Marfan's and Ehlers-Danlos syndrome, or when the aortic root diameter is more than 4.5 centimeters square. So think aorta, like when the patient has unexplained severe pain, especially retrotesternal or epigastric pain, we always think of preeclampsia or pancreatitis, but also you need to keep in mind of aortic dissection, always keep in mind. And when it comes to management of cardiovascular disorders, PAC R square. PAC is nothing but preload, upload, contractility, rate, and rhythm. If you can maintain all these 5 things normally, many a times you can navigate very, very safely in the perioperative period, and even your anesthetic you can plan. The choice of anesthesia, you have to decide what type of what is the effect of spinal on preload, on afterload, contractility, rate, and rhythm, and you can navigate quite safely. Amniotic embolism. Catastrophic presentation with severe cardiovascular collapse, severe respiratory distress, ARDS, seizure because of cerebral hypoxemia, and they're going for consumptive coagulopathy very, very rapidly. So the hallmark of amniotic fluid embolism is a clinical diagnosis. When you have an acute collapse and DIC, it is amniotic fluid embolism. When you have acute collapse, there is no DIC, it could be pulmonary embolism. When you have acute collapse with respiratory distress, no DIC, it could be again respiratory distress leading to ARDS, again amniotic fluid embolism is very high. So you need to have an algorithmic approach. So DIC, presence of DIC will tilt the diagnosis. You have to remember that pulmonary embolism will never present with pulmonary edema. They have acute obstructive shock, acute hypoxemia, and sometimes seizure also, but they don't have pulmonary edema. So subtle clinical variations, clinical features, you can diagnose pulmonary embolism. There are no clinical blood markers, serum tryptase, all these things have been mentioned, but there are no proper histopathological diagnosis, because even if you take out samples for from the central line or pulmonary artery, you can see fetal chromosomes even in normal pregnancy. So presence of fetal chromosomes in the pulmonary blood is not a hallmark of pulmonary amniotic fluid embolism. It's a clinical diagnosis. But the beauty of amniotic fluid embolism is aggressive multi-organ supportive management, patients survive. We have had last 23 years of OB practice, 5 cases of amniotic fluid embolism, 80% survival rate, and this was without ECMO era. This was before 2010, and they survive. The only thing is I must mention that all needed peripartum hysterectomy, all needed multiple transfusions. When I say multiple transfusions, more than 15 units of blood and blood component therapy. 2 patients needed recombinant factor 7A. 1 patient needed bone ventilation and was mechanically ventilated for 29 days, but recovered quite well. So the bottom line is, whenever you have amniotic fluid embolism, go for aggressive multi-organ supportive therapy and go for the best type of care that you have in your hospital. If you don't have, stabilize the patient and transfer the patient to a place where you have this facility. Anaphylaxis protocol, yes, intravenous adrenaline, intramuscular adrenaline, drug of choice along with hydrocortisone, 0.5 grams, 0.5 grams, 200 milligrams to 500 milligrams hydrocortisone has to be given along with AVIL. But importantly, have a low threshold to use adrenaline. We have almost about last again 20 years, we have almost about 9 to 10 cases of anaphylaxis presented with severe shock, with perioral edema, laryngeal edema. Fortunately, all survived. Not a single patient died. Last anesthetic cause, local anesthetic systemic toxicity is very, very rare. Fortunately, we have not seen a single case either in anesthetics or in labor analgesia. But you need to have availability of lipid in 20% intralipid in your refrigerator. Generally, we have lipid availability in labor room, in the post-operative ward, and at the end of 3 months before the expiry, the labor room intralipid is transferred to ICU so that we can use it as a nutrition therapy, parenteral nutrition. But availability of intralipid is mandatory, because we all know that local anesthetic systemic toxicity, especially following bupivacaine, it reverses rapidly with lipid emulsion transfusion. Generally, we give about 20 to 30 ml per kg rapidly over 1 hour, about a liter of 20% intralipid, and most of them they reverse quite rapidly. Again, as I said, we have not used, so I don't have the personal experience, but the literature mentions that a liter of intralipid over 1 to 2 hours, most of the patients recover from the lignocaine amide toxicity. Magnesium sulfate, again, can rapid bolus can cause magnesium toxicity, and 1 gram of calcium gluconate or 2 grams of calcium gluconate can reverse magnesium toxicity. But you have to remember that whenever you're giving calcium gluconate or calcium chloride for reversing MAC-self, you're also reducing the threshold for seizure. So you need to keep in mind that patient can seize. So accordingly, you have to keep in mind about ABCs. Anaphylaxis, as I said, yes, adrenaline is a drug of choice. Again, Murphy's dictum, you have to remember, anything that can go wrong will go wrong, and you must be prepared for all possibilities. So all this collapse or near misses eventually can end up with cardiac arrest. And whenever you have cardiac arrest, you need to give high quality BLS, and BLS to ACLS duration ideally should be less than 1.5 to 2 minutes. And ACLS to perimortem cesarean section again should be less than 2.5 to 3 minutes. So basically, if you cannot achieve ROSC within 4 minutes from the time of cardiac arrest, you should go for perimortem cesarean section. This is very, very important. During pregnancy, perimortem cesarean section is a part of ACLS protocol. As I said, CPR in pregnancy should be CPCR, and always go for splanchnic resuscitation, because many a times excessive usage of adrenaline, noradrenaline, and vasopressors can cause severe splanchnic ischemia, can cause gut mucosal disruption, and then sometimes patient can go in for delayed multi-organ dysfunction syndrome and maternal mortality. So postpartum and post resuscitation care is of paramount importance. We all know that whenever you have cardiac arrest in pregnancy, the factors that have to be considered is uterine blood flow. Almost non-pregnant uterine blood flow is 2 to 3%. Pregnancy, almost 30% of cardiac output goes into uterus during pregnancy. And you know that pregnancy again is a high cardiac output, low SVR rate. The cardiac output increases by 50% to supplement the fetus. Aggressive BLS, aggressive ACLS is what is important. The things that we have formulated guidelines, the Association of Obstetric Anesthesiologists formulated the task force guidelines, and I don't want to go into the details, but in addition to guidelines of AHA in pregnancy, American Heart Association guidelines of 2015, which are modified again in 2018, we came out with certain additional recommendations because of our experience in peripartum cardiac arrest. Judicious usage of oxytocin is very, very important, because many times you achieve ROSC and 70% of patients, they develop atonic PPH, our experience. So one of the recommendations for atonic PPH is oxytocin infusion. And again, we have seen a recurrent cardiac arrest following ROSC with the usage of oxytocin. So have a low threshold to use compression stitches. And again, these are recommendations. So low threshold for usage of compression sutures for atonic PPH. Judicious use of oxytocin, you have to have balance of methyl ergometrin, carboplastomethamine, oxytocin, and even rectal other uterotonic agents. Other thing that we came from our experience is usage of presence of vascular clamps in perimortem cesarean section sets. We all know that incidence of adherent placenta, when we started our practice, was we did 4 or 5 peripartum hysterectomies in a year. Now we do almost 2 every 2 to 3 perimortem cesarean section, peripartum hysterectomy every month. So increased incidence cesarean sections have led to adherent placenta increased incidence. And we had one case of a patient with placenta percutata with cardiac arrest, and the surgeon was reluctant to open up because of delivering the patient with percutata leading to hemorrhage. So then we came up with this idea of putting vascular clamps as a routine in PMCS set, so that just deliver the baby, either clamp the common iliac and clamp the aorta. It is not easy to clamp aorta and common iliac, but again, CPR drills and repeat drills, recurrent drills, you can acquire this skill. There's no magic rocket science in this, but definitely it is a life-saving device. So presence of vascular clamps in placenta percutata cases, if at all this patient needs perimortem cesarean section, is of tremendous usage, because you can minimize subsequent blood loss because of clamping of major vessels that supply blood supply to the uterus. The fourth thing that we have recommended as a part of AOA task force guidelines is multi-organ protective support should start immediately post ROSA, because we know that once we achieve ROSA within 4 to 5 minutes, or once the perimeter cesarean section is done, the completion cesarean section, or often they end up with the peripartum hysterectomy, it takes almost about 2 to 3 hours in the theater. And these 2 to 3 hours are very crucial. So organ protective support should start right from OT, like lung protective ventilation, putting an orogastric tube, inducing mild hypothermia, like around 34 to 35 degrees. It can begin right in the operation theater rather than reserving it to post-resuscitation care in ICU. Because this 3 to 4 hour earlier resuscitation, early organ protective support is of paramount importance. Again, this is not our guideline, but already AHA guideline. Have a low threshold to put ECMO. We have had about 6 cases of ECMO in pregnancy with a good outcome. And if you see this patient, it's almost about one patient required ECMO for 27 days. This patient required ECMO for 9 days. The video is not playing, but she recovered quite well. Both the patients had mitral cardiac arrest, antepartum, recovered very well, stabilized, and they put on ECMO, and they went home alive. When to stop CPR following collapse, cardiac arrest also is an ethical consideration. I don't want to go into the details, but you need to have a protocol of organ donation because they are the best organs available for the organ recipients. You need to have your own protocol for mitral cardiac arrest, mitral collapse, and you need to be familiar with your own protocol. You need to have regular drills. I'll just conclude my talk with this case, which came with florid pulmonary edema. If you see, came with florid pulmonary edema, arrested, and we had to do perimortem cesarean section in the labor room. Baby delivered in high dependency unit. ROSC was established, was shifted to emergency theater, and then cesarean section was completed. And this patient, they recovered. She recovered completely. Basically, mitral cardiac arrest, pulmonary edema, delivered in SDU. This was a case of non-compacted left ventricle. So basically, outcomes are pretty good if your resuscitative measures are good. But when you analyze the cases of acute collapse acute collapse and cardiac arrest in pregnancy, it is often the substandard care and poor resuscitation skill that led to poor outcome. And they have been repeatedly identified as the contributing factors of patient mortality and morbidity. So you need to have more drills, proper drills. And it will be good to see a happy couple with a live child at the end of cardiac arrest. And this was another case, like as I said, non-compacted LV, cardiac arrest. The father is proud holding the baby. The mother refused to take the photograph of her. So father was taken, the picture of father was captured. But more importantly, it is the mother survived, the child also survives if you give aggressive management. So the lessons learned is eternal vigilance, regular protocolized drills, and post-resuscitation care is very, very important. My colleagues are there, one is obstetric Shailaja, one is anesthetic Shailaja in our hospital. And we run these drills every quarterly. Every new batch that comes, they go through this one-day program where they get the feeling of obstetric part of critical care and anesthetic or critical care management of various situations like hemorrhage, eclampsia, hypertensive crisis, shoulder dystocia, and so on and so forth. So regular drills should be the norm in your hospital to have good outcome. Again, this was a case, we received this case 1 week after the previous case, which I discussed, of mitral cardiac arrest, BP of 60/40, unconscious, feeble pulse. They thought it was a case of severe cardiomyopathy. And we took her up for cesarean section. If you see, the diagnosis was cardiovascular shock, intrauterine fetal demise, query abruption. But to our surprise, it was a ruptured uterus with fetus floating in the peritoneal cavity. So you just have to have EFAST in your hospital. Acquire the skills of doing EFAST, ultrasound, abdomen, echo. You need to get those skills done so that you can get a right diagnosis and of course, good outcome. So to conclude, acute mitral collapse, have a common, uncommon causes in your brain studied, and you have to have these algorithms repeatedly occurring so that, and this can happen only when you have a regular drill incorporated in your curriculum, in your practice. I would say quarterly, drill is very, very important. Time is crucial. Rapid primary obstetric survey, secondary survey, not to miss out anything, especially when you have pregnant trauma cases. The ATLS protocol of primary survey, secondary survey, tertiary survey should follow. ABC, CAB is vital. Again, as I said, the MCA algorithm is CAB, but in pregnancy, we all know that maternal oxygen demand is very, very high, and ABC, CAB has to go simultaneously. If you don't have facility, stabilize the mother and refer to a higher center early. Again, many times the referral to a higher center, you need to have a proper communication so that they receive the patient, and you should not send to a center which doesn't have proper facility. So you need to have a protocolized transfer. Okay, this patient probably just needs only ventilation. So only center which has ventilator therapy should suffice. Or this patient needs ventilation plus dialysis plus cardiac intervention. So accordingly, you need to triage the patient and transfer the patient to a proper center. Very, very important. Otherwise, the patient is transferred to elsewhere. They don't have proper facilities, and time may be lost. So every moment is precious and crucial. Metal cardiac arrest, perimeter cesarean section within 4 to 5 minutes is the rule, should be the norm, is a part of ACLS algorithm in pregnancy. Post-resuscitation care should start in operation theater at the site of cardiac arrest, at the site where you achieve ROSC. Not to wait till the patient is transferred to critical care unit is very, very important. And functioning of multidisciplinary team is of paramount importance. So high quality CPR in pregnancy is mandatory. Death is always clear when it's untimely, and it's a double jeopardy because not only the mother, but we also lose the fetus. Thank you very much for your kind attention. I think 7:55 was the time that I was told to complete. Thank you very much, sir.
That is not an issue at all, Sunil, because listening to you is something, actually, it is very, very interesting and exciting. Therefore, I don't think time is an issue. I will just take a couple of questions before I think we head to the next topic. The rest of the questions maybe we will take at the end. Sunil, will you be there till the end?
I'm there till end.
Okay. We'll just take a couple of questions. There's a question, do you recommend prophylactic use of Tranex in all LSCS cases?
No, we have debated this very, very
I know.
earlier also. So the thing is, prophylactic usage of tranexamic acid is not recommended. But yes, when the patient has risk factors for postpartum hemorrhage like multifetal pregnancies, rare blood group, or has even mild atonic PPS, then you can go for it. Because it has been found out that prophylactic tranexamic acid, even though the thromboembolic event have not been studied, but there's one ongoing study which is going on. The results will be ready by this year, where they have compared a low-risk parturient for elective cesarean section receiving tranexamic acid versus high-risk parturient where tranexamic is being given. So probably we'll be having the data, but as of now, no.
Okay, I agree. What's your opinion about inadvertent use of prostadine? I wonder what is inadvertent use?
See, again, many a times, when I was doing my post-graduation, every case I remember giving intravenous methyl ergometrin. Intravenous, methergine 0.2 milligrams. During my post-graduation, apparently nothing happened.
Yeah, even we have used.
Yeah, when we read more of obstetrics and then plunged into obstetric practice neck deep, we realized that methergine has its own, and we did 2 cases of coronary spasm and myocardial infarction, ischemia also with coronary with methyl ergometrin. So we stopped using methergine. Probably we use, I would say, only in case of atonic PPH when it is indicated. So coming to carboprost, yes, again, same thing applies to carboprost also. Because carboprost, especially in the subsets of cardiovascular or pulmonary diseases, it can increase pulmonary hypertension. So routine usage is not advocated. But yes, when you have the first line uteronic agent like oxytocin is failing, then yes, definitely it is indicated intramuscular carboprost.
Yeah.
Not as a routine.
Yeah. Yes. There was another question on routine use of ergometrin. Obviously, it should not be used. I agree. You just highlighted that. Last question before we move on is there any role for a routine echocardiogram in every patient who comes for LSCS?
See, this has been often, again, a debated topic in obstetric conferences. And I feel it is always, we have seen sudden acute collapse following a cesarean section and we realize that this patient has cardiomyopathy or mitral stenosis and presenting with pulmonary edema. So there is no harm in doing a routine echo if you have the facility in the town. But having said that, if you put it as a protocol in remote practice in rural areas, it becomes difficult. So for presence of persistent tachycardia, insidious onset of breathlessness, breathlessness at rest, paroxysmal nocturnal dyspnea, these are the PND and breathlessness at rest are not normal signs. They are not normal signs. I mean, they're not normally present in parturients. So any of these signs that are present, then yes, have a low threshold. In addition, hypertensive parturient, obese parturient, multiple comorbidities like obesity, GDMs, and hypertension, then ECG echo are routinely advocated. But routinely for all, I would say no.
No, it's pretty difficult in our scenarios to do it. And I don't think it is indicated. We only restrict ourselves to where the history or physical examination points to
absolutely
requirement.
But 5 years down the lane with ultrasound present in virtually every theater, I think, and most of our anesthesiologists acquiring the skills of doing EFAST and lung ultrasound and heart ultrasound, probably putting a probe on the chest.
Maybe, you can run the probe towards the heart and then see. Yeah, I think it doesn't do any harm anyways. The last question is, anyway, the president wanted to know what's your opinion on IV oxytocin bolus. I think
IV oxytocin bolus is like issuing a death warrant in patients with cardiomyopathy or heart diseases.
Yeah,
so we never know. There is no role of IV bolus, but always give as an infusion. Always as an infusion.
Yeah. The rest of the questions, I think, Sunil, we will take it at the end. Now we'll move on to labor analgesia because
in between, Praveen, can you post that we have the just for the benefit of everybody? It is not with that. The Kerala is conducting the state conference. Will be an e-conference that is one day on 1st of November. The screenshot, you will put that, request everybody. There will not be a registration charge, but people have to register. No registration charges, but register. Praveen has posted that just for the information. In between, I asked Praveen to post that. And that is Kerala.
Sunday.
I must tell you at this juncture that even the AOA conference on 25, 26, 27 September, which was at Kolhapur, we are doing it as an e-conference. The details will be sent shortly.
Oh, okay.
Okay, that's wonderful. That is wonderful.
Yeah. But it will be for 3 days, Sunil.
It will be 3 days, but 2 hours, evenings.
Okay. That's nice.
This will be a full day conference. Kerala WebCon will be a full day conference from 9 a.m. to 5 p.m. on a Sunday.
With the PG paper and everything.
Wow, but, nice. But the breakfast, lunch and dinner?
At your home. There is a break. There is a break for lunch. There is a break for lunch.
Okay, nice.
There is a break for lunch.
I think during the next half of the question and answer, I think, Praveen, you can display this.
Yeah, now we will close that. Just it is for the information of people, then he will again. And I have to inform you that your founder president, AOA founder president, Sunanda Gupta is there among the audience. We recognize her presence.
Yes, surely. Yeah. She is supposed to be she's famously known as the mother of obstetric anesthesia. Even
we recognize her.
Lalit Raigar is there. I think it is great to have you all around.
Great to have you all. Yes.
Yeah, nice. That's very nice. Right. Yeah, now we move on to the next lecture. Dr. Joe John Chirayat, Gopa is talking.
It was an excellent presentation, Dr. Sunil. Since we are having discussions at the end, we are moving on to the next session. The delivery of the infant into the arms of a conscious and pain-free mother is the most exciting and rewarding moments in medicine. There is Moi's words. And we are today lucky to have Dr. Joe John Chirayat. And I welcome him. He completed his MBBS from Government Medical College, Thrissur in 96. Did his MD at St. John's Medical College, Bangalore in 2000. Passed FCA, RCS and MRCA from Royal College, Ireland in 2006. MRCA from Royal College in London in 2010. And he worked from 2002 to 2013 in UK. And in the last 3 years, he was the consultant there at Royal Shrewsbury Hospital, UK. And over to you, Dr. Joy John.
Hello there. Thank you very much. I'm just sharing my screen. Can you just enable my screen to be shared, please?
Yes, sir, it is enabled. You can click on share screen, sir.
It's coming as disabled, actually.
You are the co.
It will be another one.
Just try once more, sir. Otherwise, I will share for you.
Yeah. Okay. Yeah, it's coming as host is disabled the participant
Okay.
screen
No
sharing.
problem. Just go on, sir.
Can you just put it onto slideshow, please? Okay, so good evening, everyone. And thank you, ISA Kerala chapter, for this great opportunity. Thank you very much for the introduction. So now, moving on to the topic. Can we just go on to the next screen? So the topic is labor analgesia and recent advances, and that's me. Binin. Shall I try sharing my screen, Binin, once more?
Yeah.
If you can just enable the screen sharing.
Just try, sir.
It's still coming as host is disabled the participant screen sharing.
Praveen,
Just,
can you just help him out? Or Shilpa?
Sir, ha.
ಎಂತಾಗಿದೆ?
ಇಲ್ಲ ಸರ್ ಅವ್ರು co-host ಮಾಡಿದ್ದೇವೆ ಸರ್. You are the.
this is actually from a different. One is my phone and one is my computer.
What's
What
the
is the
name,
name?
sir?
Joe, J-O-E.
Okay, 1 second. Only J-O-E. Okay.
Yeah. It'll
Okay.
make it much more easier. That's why.
Yeah, of course.
Yes, sir. Now I made that Joe as co-host. Now you just try sharing the screen, sir.
One minute.
Yeah, it's happening.
Yeah, good.
We can see Joe. You can
Yes.
carry on.
Okay. Yeah. Sorry about that, but I thought I'll save Binil of some work. So along with me, I bring regards from Amala Medical College, Thrissur, which is around 100 bedded tertiary referral hospital in Thrissur. You can see it is actually quite among a sort of quite a green part of Thrissur. It's quite a scenic place. I welcome you all to visit it at some stage. Now, doesn't that look quite worrisome for an anesthetist? We are supposed to be pain relievers, and somebody lying like that is not what we want to see. I'm sure if it is a post-op patient, we would have dealt with it. We have so many things to deal with, like you put an epidural, we'll give that, this, drugs, everything. But when it comes to pregnancy, are we that keen? I think we should be. So what we need is an on-off switch. So we need a switch to put that off. So what are the different things that are available in the market or that are there for ladies to use, which do help in relieving labor pains? One is Entonox. As we all know, it's 50% nitrous oxide and oxygen. The important bit is to teach the parturient about when to use it. So as soon as they think that they might be having a contraction, they should use it, because it takes around sort of 20 to 30 seconds to start working, and then it takes around 45 seconds to reach a maximum effect. So you should basically teach them to use it well. The other thing is that you should tell them not to keep on using it, because what will happen is, as we all know, Entonox, it has sort of, it can make them a little bit sort of drowsy. So the nitrous oxide in that. So they shouldn't be keeping on using it, but use it when needed is how you should teach them. Now, the next thing is parenteral opioids. We all use it in our hospitals. One is pethidine at a dose of around 1 milligram per kilo IM. The important bit here is the maximal fetal plasma concentration is after around 2 to 3 hours. So if the delivery is happening at around that stage, it's better to tell the pediatrician that this baby might be a little sedated because of the pethidine that has gone in. So they might be sort of interested in looking at it, maybe thinking about naloxone and things like that. So the peak effect is around 2 to 3 hours. The next one is morphine. Now, morphine at a dose of 0.1 milligram per kilo is supposed to have been tried. Most of the places actually do try pethidine. One of the reasons I think when you ask around is, and when you look at evidences, basically because of the longevity. It has been something that is there used for quite a long time. So people are used to it. And the second thing is that morphine, if you look at evidence, sort of makes the parturients a little bit more sedated. So in that way, probably pethidine is probably the more preferred drug. Now, the efficacy because of these, there's no real evidence that it is basically because of analgesia. There are schools of thought that the happiness that the patients have, the satisfaction that the patients get, are partly due to the sedation rather than the analgesia. Tramadol has been tried. Now, it was generally found, compared to the other opioids, that mothers had a higher pain scores with tramadol. Fentanyl, remifentanil, we'll come to that towards the end of the talk. So now, coming on to, I'm sure that this is what you guys want to hear about, is regional techniques for labor analgesia. That is the gold standard. Everywhere it is written like that. All the evidence points towards that. The different ways of doing it is, one is a caudal epidural, which has been tried, but probably a little bit cumbersome. Getting a caudal in an adult is not that easy. Pregnant lady, even more difficult. Combined spinal epidural, that has been tried. We'll come to the details in a bit. I'm just sort of narrating what we are going to go through in the coming slides. Lumbar epidural is the most common, of which it can be an intermittent bolus, it can be a continuous infusion, it can be a PCA, that's a patient-controlled epidural analgesia, it can be a programmed intermittent epidural bolus, computer-integrated PCA. Okay, quite confusing, so many words. We'll come to each of these a little bit later. So what are the major advantages of labor epidurals? Evidence supports maternal satisfaction. Yes. Obstructed labor, again, if the baby is in an OP position, occipital posterior position, if there's an obstructed labor, the gynecologist might want you to put in an epidural, and there is evidence that it might help in getting the baby come out the normal way, because it will sort of prevent the lady from keeping on straining, and that might ease the way for the baby. Certain high-risk obstetric cases, like if you don't want the patient to be sort of struggling a lot, PIH, and some cardiac cases in which an SVR drop might not be a big issue. So that means most of the cardiac cases, it can be given. Now, when I say cardiac cases, somebody might be here thinking about if it was few years back, probably not, because those times you're using a higher dose of the drugs and the BP fall was more. But nowadays, with low concentration ones, it is much more hemodynamically stable. It's been found that there is less fetal acidosis when the baby's pH was checked, especially so when it was an obstructed labor. So now, just to make things into perspective, I did all labor without an epidural, just so that I could tell everyone what a joyous experience it was. Now, this card says that no one has said that ever. And the reason is because when you have an epidural, why don't you have it? You cannot have a joyous experience without an epidural. When I say that, once in a while, yes, but not all the patients. Whereas if your epidural works, that's the gold standard. It is that off button. Now, what is the incidence of labor epidurals being done? First of all, in 2018, WHO has recommended epidurals. There was a statement made on 17th of February 2018 by WHO, which said because of various reasons, epidurals are laboring ladies should be offered epidurals. In the US, from the evidence I could get, it is approximately around 70%. In the UK, on an average, NHS 30%. So that means some hospitals is around 60%, some hospitals lesser than that. So on an average, around 30%. In India, as we all know, it's much, much lesser. But I'm sure in the future, there are going to be anesthetic teams exclusively for providing painless labor services. So for the juniors out there, for the guys who are coming out post MD, look, there is some scope here. There is a subspecialty. I won't say subspecialty, but there is a job here waiting for you. Now, what all are the risks I should tell the patient when I'm going to do an epidural? As always, it has to be the commonly occurring ones and the serious ones. So what are those with regards to a labor epidural? The first thing is failure. When I say failure, it's not absolute failure, but our patients might have actually spoken to somebody else in whom it might have worked 100%. So their expectation is as soon as I have an epidural, I'm just not going to have any pain, which might not be the case. So that is what we call as failure, where they were not really happy about how it went off. So that is approximately 1 in 8 patients. They might not be extremely happy. A drop in blood pressure, less than 1 in 50. A severe headache, so we know that that's mainly because of a post-dural puncture headache. So if it's a post-dural puncture headache, if somebody's incidence, when I say incidence of somebody, that means an experienced anesthetist having an incidence of more than 1 in 100 of PDPH, then it is time to revisit your technique. There is something wrong in your technique, so you have to revisit it. Nerve damage, a temporary one, usually in and around the L1 region, less than 1 in 1,000. A nerve damage, which is not that long-standing. Yes, 6 months is long-standing, but it's probably less than. It's lesser than the other one that you're going to see, which is written in the bottom, 1 in 250,000. So this one is actually less than 1 in 13,000. Okay, a nerve damage which will usually recover. Epidural abscess, rare. Meningitis, rare. Epidural hematoma, very rare. Accidental unconsciousness, reasons not known, rare. And severe injury is extremely rare. And that is from the Obstetric Anesthesia Association UK patient information leaflet, which every patient has. You're supposed to tell every patient that. Next is, when should I put an epidural, labor epidural? So there was a conventional thought, like in the sense, like the patient should be in established labor. So when is labor? When can you call the labor is established? In primaries, around sort of 4 to 5 centimeters. In multis, a little bit earlier, so 2 to 3 centimeters is what is being said. But probably we shouldn't be sticking on to that because of the evidence. So in this study, an RCT of 750 primary gravid women in early labor, there was no difference in the cesarean rates when the neuraxial analgesia was administered early in labor, that is 2 centimeters, versus late in labor, 4 to 5 centimeters. So it didn't make any difference. So even if you put it early, nothing wrong actually. Now, the next one is the American College of Obstetricians and Gynecologists recommendation. They have said that you don't have to wait till the cervical dilatation has reached 4 to 5 centimeter. And they've endorsed a statement saying that maternal request is a sufficient indication for pain relief in labor. Now, position. You can actually do it in the lateral positions or sitting positions, but I personally would prefer a sitting position for a laboring patient. One is because the patient by themselves will sort of give you a position. You don't need that many people sort of trying to make that position for you. But one thing to remember about is a laboring patient is a moving target. So you might better be a little bit strict to them, more than strict. You might be better telling them the problem of them being a moving target to you. Okay, so once you tell that, yes, I know that with the patient, you are not supposed to be, you are supposed to be very mild and gentle and things like that and all. But if it can cause a harm, I don't think there is a problem being a little bit sort of letting them know that what might happen. Because in the next 10-15 minutes, once the epidural starts working, they're going to forget about all the other things that happen, and you are going to be like God. Okay, so that's the good thing. That is the satisfaction that this thing gives. So basically, a sitting position is what I would recommend. Now, what I tend to do, now with pregnancy, we know that they can be heavy. They might have put on weight. It might not be an easy procedure to do. They might bleed a little bit more and things like that. So what I tend to do is I sometimes, if there is a difficulty, I tend to tilt the bed towards me a little bit. So when I tend to tilt the bed a little bit towards me, the patient, so that the patient doesn't fall back, tries to exaggerate and sit forwards. That gives me a little bit more space through to reach the epidural space. So when somebody has a problem getting an epidural, and if I am called, this is a slight ploy that I usually do. I just slightly tilt the table a little bit towards me. Now, how should you identify the epidural space? The recommended way to do it in labor epidurals is with loss of resistance to saline. And the reasons for that is with pregnancy, we all know that the chances of a bloody tap is much more higher because the epidural veins are engorged. So by having a loss of resistance to saline, what you can do is once you reach the space, you can inject a little bit of saline, keep the veins away a little bit, and try to get the catheter through that. Now, suppose you're used to loss of resistance. Can you hear me now?
Yeah. Yes.
Yes, you're audible. John, please continue.
Now, suppose you're using your loss of resistance to air technique. What can you do? As soon as you reach the space, get a little bit of saline, inject the saline to keep the veins away, and then put the catheter away. The second reason is to cause less patchy blocks due to the air pockets that are formed around the nerves. That is another reason why you probably should do it with saline. The third is rare, but there are case reports where they thought that the patient had an issue because of air embolism. It is rare. How much of epidural catheter should be left in place? The general sort of evidence tells you that it is around 4 to 5 centimeters. From 2 to 5 centimeters has been recommended, but roughly around 4 to 5 centimeters. The reason is not too less because it can come out. This patient might be wiggling, might wiggle on the bed. She's going to lie like that for some time. So it can come out, and especially if it's an obese patient, there is an even more chance of it coming out. And not too much, because if you put too much, there is a chance that it can become a one-sided block by going through the intervertebral foramina. The next controversy is epidural test doses. Classically, most of the places they say about a 3 ml bolus of 1.5% lignocaine with 1 in 200,000 adrenaline. So that means around 5 micrograms per ml of adrenaline. Totally will come to 15 micrograms of adrenaline. Normally, a 20% increase in the heart rate or 10 to 25 increase in heart rate within 1 minute is supposed to tell you that it is an intravascular placement of the catheter. Now, that is normally. In pregnancy, the problem is in between, they might have sort of a labor pain, and you might not be able to get that rise in heart rate correctly. So that is the dilemma. So now, what are the controversies? One is Miller's textbook. It does not recommend adrenaline, and suggests that low concentration of the local anesthetic would give you neurological symptoms if it is an intravascular injection. Whereas Testbook, it supports an adrenaline test dose, but it says that 30 beats per minute. I would assume that is because of the chances of a heart rate increase in pregnant ladies being much more higher. So they have gone for a higher rate. Okay. And if the patient is beta blocked, then you're looking at the blood pressure because the heart rate won't work. You're supposed to look at a blood pressure of more than 20. Now, how easy is that? You ask me, I don't know the answer because the non-invasive blood pressure, to rightly pick it up going more than 20, I don't think it's going to be that easy. Snyder's textbook does not clearly recommend adrenaline. So that is what evidence tells us. So personally, I do not add adrenaline, and reasons is though they are quite sensitive, they're not specific and might lead me to do a lot of more unnecessary recycles. So what I do is I rely on something called the drop in meniscus sign. Quite a few of you must be knowing it. Basically, for those who are new to it, this is what it is. So basically, as soon as you reach the epidural space, you put in the catheter there, and then 1 ml of saline and 1 ml of air and 2 ml of saline, you inject it through the epidural filter. Then you take you just remove everything, remove the filter and everything, and then slightly the open end of the epidural catheter is lifted up. When it is lifted up, the liquid meniscus goes down. So if it goes down, to me, it tells me that it is going into a big space. Now, the next possibility is a paravertebral space. Because paravertebral space is a potential space, it's not as big a space as an epidural. What I do reckon is the drop in meniscus, it won't happen as how it happens with an epidural space. Now, does it happen all the time? I won't say all the time, but most of the times, this when you're sure about the epidural space, this does go down. Then what you tend to do is you lower the end of the epidural catheter and see what comes out. Because the fluid has actually gone in and come out, if there is no blood in that, if there's no blood tinge in that, then that should not be in a vessel. And the other thing is that if the air somehow comes out, then that can't be CSF as well. So yeah, so this is a way how to do dropping meniscus sign. Next is, what is the epidural solution that can be used? The most recommended ones are bupivacaine 0.1%, but with fentanyl, or ropivacaine 0.15, even up to 0.2%. Sorry. I hope you can hear me again.
Yes, sir.
Yeah, okay. So now, other drugs. What are the other drugs that have been used? One is levobupivacaine. Why levobupivacaine is because it has 50% less toxicity compared to bupivacaine. Bupivacaine is like levobupivacaine, it's only a levorotatory one, a little bit more specific, less cardiotoxic. So that is why it's supposedly a little bit more advantageous. If you look at the relative potencies of ropivacaine, levobupivacaine, and bupivacaine with regards to epidurals, it is supposed to be 0.7 to 0.9 to 1. When I say 0.7, there is a range. Some literature says 0.6 to 1 with levobupivacaine and bupivacaine. With regards to levobupivacaine and bupivacaine, they say 1:1 somewhere. So, but roughly it is 0.7, 0.9, 1. Other things that have been tried, I've never used it, never used chloroprocaine never used that drug at all. And lignocaine, I've never used it for a labor epidural. Chloroprocaine, basically the advantages of it was a quick onset. So what they say is, if you're going to top up your epidural for cesarean section, it might be a good drug. But the problem for labor epidural is very short acting. So because of that, you'll have to keep on topping it up. So I couldn't find any literature where they've used an infusion of it. So not probably a good idea. Lignocaine, the problem is tachyphylaxis. So again, as an infusion or keeping on giving it might not be a good idea. Now, there are things like this available now. So if anybody is doubtful of what what the ladies are telling us. Like, look, I had a lot of pain and things. So if you think that they're not right, probably this is something to try on, and we can see how bad it was. But I'm almost sure that it must be that bad. Otherwise, they wouldn't be telling it just like that. Now, how all can you give it? One way of giving it is by intermittent top-ups. It's relatively safe. There's no need of any complex infusion device. The problem is it might be labor intensive, because around 45 minutes to an hour, they'll start complaining of pain, and then you might have to go and give it again. So you need somebody there. But these patients can communicate with you. They can call you. So yeah, but still. The bolus dose usually is around 15 to 20 mLs of a solution in a standard sort of height patient. 15 mLs, sort of Indian population, 20 ml, probably you can go up to that. Top-ups, probably around 45 minutes to 1 hour, when they say that they're starting to have pain, and if you're sure about that, 10 minutes of the solution. So how often? It is around 45 minutes to an hour that they start complaining about it. The next is the continuous infusion. So initially, bupivacaine, you have to give it as a bolus, because you have to get a level as a bolus that you give, as I told earlier, 15 to 20 mils, and then titrate an infusion to 8 to 12 mils per hour, titrated to block height. We'll come to height in a minute. It requires an infusion device, and it has been found that overall an increased dose of local anesthetics and opioid were used when it was compared to PCAs, patient-controlled epidural analgesics. So you probably were tending to give a little bit more than what is needed. But even when you look at the literatures, that dose didn't cause any problems, but the dose was more. PCAs, it allows for patient variability in local anesthetic requirement. It instills, this is actually one of the advantages that is cited, a degree of control to the woman, which may improve their maternal satisfaction. As I told, compared to earlier, it caused a reduction in the amount of local anesthetic and opioid delivered. It caused a reduction in the incidence of motor block, because the dose was not mass, the drug that you gave was lesser. The equipment required, yes, is more costly, because you need a pump for everyone. And the dose after the initial bolus is the standard one is 5 mils, the lockout 10 mils. So if you look at that, if the patient keeps on pressing it, it's around 30 minutes per hour, but this is the standard. Now, programmed intermittent epidural bolus. What this does is, we told that a PCA is not a good idea. So basically what this does is, instead of you going and giving it every now and then, you program it onto the machine. You tell the machine that after half an hour you give 5 ml, and then after half an hour more you give another 5 ml. So it gives the bolus is being told to the machine to do. So that will give the bolus. There is another one which has this program intermittent epidural bolus plus a PCA. So there you have to reduce the amount of bolus that you give, because the patient is already on a PCA, and then you can actually give a bolus on top of that. So, but again, that will be quite a little bit more probably risky. The next one is a computer integrated PCA. What that does is, it looks at the previous hour usage of the patient, and it sets an infusion. So the infusion rate keeps on varying. So it looks at the previous hour's infusion rate, and if the patient was happy, the patient was happy. If the patient was not, the patient was pressing the PCA. And depending upon that, it will increase the rate for the next hour, and so on. Yeah. Combined spinal epidural for labor analgesia. Advantages of this, there are people who actually are for it. And the advantages they cite is that is the speed of onset and the ability to prolong the analgesia with an epidural catheter. It might be sometimes advantageous if the patient is in a lot of agony, if the parturient cannot lie still at all, then this might be a good idea. You give a spinal, and then once the patient is a little bit comfortable, do the epidural. Okay, so it might not be a single setting, but it can be an idea. So in that case, what you tend to do is a fentanyl bolus of around 10 to 25 mics plus bupivacaine. So total volume around 1 ml. That was associated with greater maternal satisfaction, obviously, because what these studies mainly looked was in patients who were in a lot of agony,
combined in two groups. Epidural takes a lot of time, so the patient is still in agony for some time. The other one is like a switch. Immediately the patient is fine. So yes, satisfaction a little bit more. It again reduced the amount of local anesthetic because for around 2 to 3 hours this worked. So the patient didn't need the epidural much after that. Another method that is being suggested is dural puncture epidural. So what that means is you tend to get a Whittaker needle, do a dural puncture like a spinal, but don't give any drug, come out and put an epidural catheter 1 or 2 segments above that. So that wise, what they reckon is the drug partly, the opioid and the local anesthetic goes through that hole and gives causes a much more earlier onset of the analgesia and a bit more pain relief and satisfaction. So this is another thing that has been tried. Never done it. What is the recommended monitoring? Every 5 minutes for the first 20 minutes after giving the bolus, and then at least once in every 30 minutes. This is what is being recommended. Fetal heart rate, CTG, during and after the epidural. And one of the main reasons is very rarely, when I say very rarely, even though evidence says very rarely, in my experience, it is not that rare. It is something that you should always keep in mind. Fetal bradycardias have been reported. I've tried to find the cause about it, not known, but case reports are there. And then they immediately will have to come to the theater for a cesarean section. So something to keep in mind, if you're doing an epidural, might as well monitor the baby for some time, at least, ideally on a CTG. So what is the level of block that we have to achieve? The level of block. So let's go a little bit on to the physiology. The onset of first stage is the onset of cervical changes to 10 centimeters of dilatation of the cervix. And that has a latent and an accelerated phase. The latent phase can go up to sort of 8 hours. The accelerated phase around sort of 2 to 3 hours. And that is transmitted by the A delta C fibers, visceral pain, T10 to L2, T10 to L1. Second stage is full dilatation to delivery, that is somatic pain, pudendal nerve, S2 to S4. Now, the block height should be assessed at around 20 minutes post-insertion. When I say post-insertion, post-delivery of the drug, post-delivery of the full dose, I would recommend giving a small dose first, as a test dose, just to see for any neurological complication, motor blockade, then give the rest. So after you've given that full dose, then 20 minutes, and then every 30 minutes by the midwife. Again, they're called the midwives here, nurses. The preferred level, the ideal level is T10 to L1 during the first stage. Why L1 is, this is what you call sort of nowadays, there's a big talk, not nowadays, probably since the last 10, 15 minutes, 10, 15 years, there's a big talk about walking epidurals and things like that and all. So what they mean is you shouldn't have any motor block. So your L2 to L5 should be fine. So in an ideal world, what blocks you want, it should be T10 to L1, but usually be a little bit careful, even though you say walking with this dose and all, I'd be really careful. If at all they're walking, I'll have somebody assisting them, holding on to them, because they can be, or they mostly are slightly at least weak. Okay, yes, this is probably a little bit more theory than practical. With regards to ioto cable compressions, they should be nursed in either a full lateral position or a supine position with an obstetric wedge, or sitting up more than 30 degrees to outwards. Any of these. So sitting up probably will be more comfortable. Now a few troubleshooting things. So does labor epidurals, does it always just go so smoothly? No, it doesn't. So if the epidural is not working at all after the initial bolus, personally, I would have a very low threshold to recite it. Okay, but you can actually try with a slightly higher concentration like 0.25 and using bupivacaine 0.25% and see. But if it's not working at all, I would have a low threshold to recite. If the epidural is partially working, unilateral, what I would tend to do is I tend to maybe pull out the catheter by 1 or 2 centimeters. In case it is gone through one of the intervertebral foramina, and I'll give another bolus dose with the non-effective side, so lower down. Okay. And then I will think about giving a dose of fentanyl, 50 to 100 micrograms epidural as well, before I think about reciting it. If there is persistent headache, that is, if the baby is in OP position, so when I say, sorry, not headache, backache, if the patient is in OP position, they do complain of severe backache, in spite of probably the low-dose epidural going on, then what you can do is you can give a slightly higher concentration of 0.25% bupivacaine to sort of circumvent that pain. Now, you rupture uterus, but as per, I've never come across a patient like having a labor epidural, having a rupture uterus in between. So, but again, as per evidence, it says that if there is a breakthrough pain, if the patient was comfortable, you didn't expect the epidurals to have stopped working. The patient starts complaining pain from lower down, then always a rupture uterus is something that you should keep in mind. It does give a pain to the patient even if the epidural is working, is what is being told. So that should be kept in mind. So some clarifications regarding labor epidural. Now these are the questions that the patients or somebody else or the obstetricians might ask us, and that is from all these references. Cesarean sections, the evidence indicates that effective labor analgesia does not increase the rate of cesarean sections. Instrumental delivery, effective labor analgesia can prolong the second stage and might also increase the instrumental vaginal deliveries. But I'll come to that in a bit. I'll come to keep this in mind. I'll come to it in a bit. But women with complicated, painful labors may request epidural analgesia more. You should keep that in mind, because the patients who are having epidural analgesia can be patients who had much more painful labors. So that might be the reason why they needed an instrumental vaginal delivery. And in those studies, at least the big studies, they haven't looked into that subgroup. Back pain, definitely there's no incidence of increased back pain postpartum. But what do I tell the patients? Because they always cite me an example. They tell me that my friend or somebody like that, or my relative had an epidural, and since that she has back pain. So how can you say it doesn't happen? Now, my answer to them is during pregnancy, 9 months, with all the hormonal changes, you tend to walk in an abnormal posture for 9 months. And if you look at the back pains of females, it tends to increase after delivery. So they have compared females without epidurals, females with epidurals after delivery, the back pain was equal. So this back pain, and obviously they will attribute that to the injection that was given in the back. So this is my answer to them. There is no evidence. Maternal temperature, yes, it does cause a slight increase in the maternal pyrexia, but that is not being related to infection. And from evidence, it is not something that we should really worry about. Systemic effects, neuraxial analgesia has been shown to improve maternal cardiovascular and pulmonary physiology and the acid-base status of the fetus. Fetal scores were found to be, if at all, slightly better at 5 minutes with labor epidurals, less fetal acidosis, and the requirement of naloxone was less compared to systemic opioids. The other thing to keep in mind is a failed epidural top-up for LSES. And just for completion's sake, I'm mentioning that. This is an article that came this year, BJ Education. The one thing to beware of, if you have done an epidural top-up within the previous half an hour, be very careful when you think that the epidural has not worked. I'm going to take that out and I'm going to give a spinal, because with the epidural, it might have caused an increase in the epidural space, which might have contracted the subarachnoid space. So a smaller dose of the subarachnoid drug is what you have to give. Otherwise, you can cause a high block. So this is something to keep in mind. And the other reason attributed is because if part of the epidural has worked, it might already have caused exposure of the neuronal tissue to the local anesthetic. So again, giving the local anesthetic might cause a problem when you're giving a subarachnoid space, when you're giving it into the subarachnoid space. There also has been, in that article, a mention about an increased incidence of failed subarachnoid blocks. And that is the reason why they say is because of contracted space, you might not be able to sort of locate the subarachnoid space. Plus, you might falsely think that the fluid that is coming through that is CSF, whereas actually it was the local anesthetic that is in the epidural space. And then you might give the drug, which might not work. The very few cases that I have sort of had to deal with this problem, I've not found a problem giving the subarachnoid, but what I have stuck on to is, I'm sure that all of you have a range. So if my range is sort of around 1.8 to 2 ml of the local anesthetic, I'll go to my lower range of local anesthetic that I give. If I was planning to give around 2 ml, I'd probably give 1.5 or 1.7 or 1.8 mils of the local anesthetic subarachnoid wise, and then I'll do all the things to avoid the block getting higher. So how do I, sorry about the spelling of higher, but how do I prevent that happening? What I tend to do is I tend to sort of exaggerate the cervical curvature. So I lift the head end of the only the head end of the table up, and I make the head with the neck very much flexed. The next thing is I keep on asking the patient. I ask the patient to squeeze my hands, or I ask the patient whether there's any numbness of the hands, just to know that, okay, is it going higher than sort of T4? Is it somewhere in the cervical region? Am I supposed to be sort of, is it reaching T8 and things like that? And all? That is my worry. Okay, and if so, then I can deal with it. And in the 1 or 2 cases, even though I have had to use, I had used the lower end of my normal subarachnoid drug, yes, the height did go up, but didn't create any serious problems. Cochrane library. Now, Cochrane, it has looked into, this was in 2011. There are 2 Cochrane library studies or looks into epidurals. One is in 2011, 38 studies involving 9,650, 10,000 females. And epidural analgesia was effective in reducing labor pain. It increased risk of having an instrumental delivery as per that of Cochrane analysis in 2011. No statistical significant impact on cesarean sections or backache, and no immediate effect on neonatal status as determined by the Apgar scores. In 2018, again, that is 40 trials, 11,000 patients, more effective in providing pain relief. More patients were satisfied with epidurals compared to opioids. Instrumental deliveries, this is the part that you have to know, were less after 2015 studies. So because since then, probably we started using lesser concentration of the drug. So instrumental deliveries now.
Sir, unmute, sir.
Can you hear me now?
Yes, yes.
So what else it tells us is no increase in cesarean section rates, no increase in back pain. As we told earlier, no differences in baby out. So 2015, lower dose is not causing increased instrument deliveries as well. So if to our gynecologists, that is what we can tell. Now, suppose you have an accidental dual puncture. Okay, so first thing to know is what is coming out of it. Is it normal saline or is it CSF? For that, you can look at the temperature, you can feel for the temperature. With the gloves, it might be difficult, but then pH, you can look at sugar or protein, which has to be there in CSF, not in normal saline. So if there is a dipstick test for sugar, then you can look at sugar content. If it's there, then it's CSF. If it's not there, it's normal saline. The next suspicion is that it's local anesthetic or CSF. Thiopentone with local anesthetic, a little bit of it will precipitate. But one thing to remember about is if it is bupivacaine, less than 0.2% bupivacaine that you have used, that might not precipitate with thiopentone. But ropivacaine, any concentration that you use, if there is a smidge of ropivacaine in it, it will precipitate. But bupivacaine, if it's a lower concentration, it might not precipitate. So that's something that we have to keep in mind. If a laboring lady has epidural puncture, you can almost tell the patient that you are going to have puncture head, because the incidence is 75% plus. And the reasons we all know is because of the increased pressures in the epidural space and things like that and all. More CSF is actually going to keep on going out. Later on, this patient most likely is going to have puncture. Now, a lot of things were tried, like they tried putting saline in, they tried doing a blood patch at the first instance itself. They tried like giving sealants through that, but nothing seems to have been the gold standard. Currently, the best evidence suggests threading the epidural catheter through the epidural needle. So if you thread it, that apparently causes stimulation of the fibroblast, which closes off the hole, and that apparently causes a lesser incidence of PDPH. From 75%, there are studies which say that it has come down to around 6%. That's a big thing. The only thing is that once you put the catheter intrathecally, be sure that you don't connect it to anything, just keep it on the back, stuck. Write it on it that look, the anesthetist is the only person who has to give something to that, and then you can use it for labor analgesia, and if needed, if they come into the theater, you can use it for cesarean section. But be very careful because it's something that rarely happens. They're not used to it. Don't give it to anybody else to use. So keep it secure and use it yourself. How long will you keep it inside? How long should you keep the catheter inside? The recommendation is 24 hours. 24 hours and take it out. 24 hours is enough to cause this fibroblast activity. Now, what is the treatment? Conservative management. Yes, by all your painkillers, those things and all. When you say conservative management, mobility, there is no evidence to say that patients lying down it will help. Giving paracetamol and things like that, no, it actually does. It just helps in patient satisfaction, but it won't help it to heal it. Things like somatropan has been tried, supposed to be effective, but again, but not the gold standard, and the gold standard is an epidural blood patch. Now, this topic was labor epidural, so I'm not delving into the epidural blood patches, but if anybody is interested to know about it, please come back to me at the question and answer session, and I'll get you. The only thing is that why and when should we consider an epidural blood patch?
Dr. Joe? I think he lost connection. Dr. Joe, can you hear me?
Dr. Binil, I think he has lost the internet
He
connection.
lost the internet connection.
Yeah.
Goma, sir, you can go ahead with your question answer.
Questions to Dr.
Sunil Pandya. Dr.
Sunil
Sunil is
Pandya.
here.
Yeah, Sunil Pandya.
Gokmal,
You can
sir.
do it.
Hi.
Yeah.
Dr. Sunil Pandey.
Sorry, I think I lost connection in between. Sorry about that. Can you hear me again?
Yes.
Okay, sorry about that. Now, so why to consider is because there is a chance of causing subdural or extradural hemorrhage. So 24.
Sorry to interfere. Dr. Joe, please share your screen again.
Sorry.
Please unmute.
Yeah, okay. It's probably only 1 or 2 slides more.
Can you hear me?
Yes, I can. I'm just not able to get my screen on. Just a minute. Can you see me now?
Yes, you are audible.
Yeah, okay. And my screen?
Yeah, you can go for
Yeah,
slides.
can see your
I'm really sorry about that. Just my connection went off in between. Now, coming towards almost the end, why I told you about that, when is probably 24 hours if the patient, if the parturian is not able to cope with her baby. So that will tell me. So next day when I go to see the patient, if the patient is lying with all the windows closed, curtains drawn down, not interested in the baby, then this patient has some serious dural puncture headaches, and I will think about having an epidural bed patch. I won't wait for long. What is the usefulness of the ultrasound nowadays with epidurals? It is supposed to cause reduced number of puncture attempts, improved success rate of epidurals on the first attempt, reduced need to puncture multiple levels, and improve patient comfort during the procedure. Something about remifentanil PCA. This is a Cochrane review in 2017, around 3,500 patients. What they've mentioned is low quality evidence. Patients, it was better than opioids, but not as good as an epidural. And there was a slightly increased risk of respiratory depression compared to other opioids. We used to have this remifentanil PCAs, but it was basically for patients who, for some reason, where the epidural was not able to be, whether it was a difficult epidural or if it was an IUD. So in those are the cases where we used to use a remifentanil PCA. I'm not probably a big fan of it. And the Respite trial that came in Lancet in 2018, compared to pethidine, it halved the conversions to epidural. So if you don't have epidural facility, then it might be okay, but otherwise not a good idea. So, honey, I think I want to name the baby after the nice young man that placed my epidural instead of after your father. Now, this might sound a little bit of an over-exaggeration, but in my experience, at least 3 times. One lady, this was while I was abroad, wanted to kiss me. So I'm not revealing what happened after that. But again, the second one was I cited this epidural in the evening, and the next day morning when I went to see this patient already had a card bought, written my name down, and she gave it to me. So you can imagine, but over the night somewhere she delivered, she made sure that she got a card and she gave it to me. And how many number of times you will hear them saying that, okay, after 20 minutes, I always make it a point, after giving the drug 20 minutes, I go down to see them to say hello. Basically, there is a hidden agenda in that. You see their smiling faces. They are usually almost always very thankful to you because it's like the plug switched off. Now, so the epidural lady, the face should be like that. That is how our lady's face should be afterwards. And I'm ready to take any questions. One of the questions that I'm expecting to come, I'll tell the answer now itself, is at what platelet count would I put an epidural? Now, 80,000, fine, there is no problem. Most of the evidence supports you. Now, when I say that, the problem is PIH, because 2 case scenarios. If it is PIH versus a purpura, ITP. In ITP, you should imagine that the platelets are normal. It is an autoantibody which has killed some platelets, but the rest of it is normal. In PIH, the number is low, and along with that, platelets might be abnormal. So don't take evidence from normality to pregnancy. So normally, in NISORA guidelines, they say that you can put an epidural if the platelet count is 60,000, but most of the obstetric sites, it is around 80,000. Some places have come down to 70,000. This is a different ball game. So don't compare, it's not like for like. Other thing to look at is if it is PIH, you better get a platelet value 4 hours within the procedure. Because if there is a dramatic fall in the platelet count, so suppose it was 200,000 yesterday, yesterday evening, today morning it is 100,000, I might be a little bit cautious in putting that epidural, because that is the rate at which it is falling. So yes, be a little bit cautious. So that's it. Thank you very much.
That's an excellent presentation, Dr. Joe. Very informative.
Thank you. Thank you.
I have some queries.
Please.
My first question, what do you think the role of spinal morphine as a sole agent if a patient demands labor analgesia when he's fully dilated?
One thing with morphine is its pruritus. Now, has it been used? Yes. In a dose of up to 200 micrograms, it has been used. And non-obstetric cases.
As a sole agent when it is fully dilated cervix.
Yeah, but the problem with morphine always is pruritus after it, because with regards to pregnancy, even otherwise, the patients do feel a little bit more itchy normally. So with morphine on board, that can be actually quite significant. So pruritus is probably one thing against it. Now, with regards to morphine as a sole agent, I've never tried it, so I'm not the best person to tell, but evidence tells me that it has been done, but pruritus has been an issue with morphine intrathecally.
Okay, fine. Well, adjuvants, other than the fentanyl and other narcotics, do you use any other like dexmedetomidine now?
Now, again.
That also, I might not be, again, I've never used it, dexmedetomidine in the past. Fentanyl is the drug. Sufentanil is one thing that has been tried, not available for us, and compared or probably said to be a little bit probably better than fentanyl. But again, as we don't have it, I don't think we should think about it too much. Dexmedetomidine, no experience.
Clonidine, can I answer that?
Okay.
Clonidine should never be used because the incidence of fetal arrhythmias and hypotension sedation is very high. In fact, if you look at one of the article published in 2004, current opinion analysis, they said clonidine and neostigmine are the new drugs that are going to replace the anesthetics.
So they can't hear you very much.
It died down because of the side effects on the fetus. So it is not recommended as such for labor adjuvant, for labor analgesia.
So about dural puncture epidural, what size spinal needle you use usually?
Sorry, once more, can you
Dr. Joe, can you hear me?
Yeah. Yes, I can. Yes, I can.
For dural puncture epidural, no? You describe the technique. And what size spinal needle do you use for that?
Not a spinal needle. If you have used your epidural needle, and through that, if you have had a dural puncture. So your normal epidural needle, you have had a dural puncture. Through the same epidural needle, introduce the epidural catheter intrathecally.
Okay.
So the same epidural catheter intrathecally, and then keep it in there. Okay. I hope I'm clear.
There are two things here, if I understand your question. One is dural puncture epidural technique. Other thing is inadvertent dural puncture management.
So this is a dural puncture epidural technique.
Yeah, if it's a dural puncture epidural technique, then we use a needle through needle 27 gauge Whittaker long spinal needle.
Okay. Usually for spinal catheters, we put 28 French, no? So the 27 spinal needle will be ideal.
You just have to you want to make a hole, and you want to make that hole with as small of a needle as possible, because again, PDPH is another issue. So with up to 25 gauge is what has been recommended. So something sort of smaller than 25 gauge or smaller needle, and prefer.
Now, what I feel is if you're for the dural puncture technique, if you're using the same epidural needle, then the PDPH chances are very high, no?
See, we don't use epidural needle for a dural puncture epidural technique at all. So dural puncture epidural technique is
27 spinal needle will be ideal. Okay.
Identify the epidural space, introduce a 27 gauge Whitaker needle, not a pencil point needle, because we don't want to give post-dural puncture headache. Introduce long spiral needle, Whitaker needle, remove the Whitaker needle and thread the catheter and manage epidural subsequently. But again, the newer literature after the landmark study by Lawrence Sen et al. In 2012, now the literature supports that dual puncture and standalone epidural, there's not much of a difference, whatever the advantages that were mentioned earlier. Coming to management of inadvertent wet tap or a dural puncture. Generally, what we follow at our hospital is whenever you encounter a wet tap or a dural tap with the epidural needle, not to panic. Push the stylet back, plug the hole temporarily, and load 20 micrograms of fentanyl. And then subsequently advance the epidural needle by another couple of millimeters, because the dural puncture may be a partial dural puncture. Only the tip of the Tuohy needle might be into the subarachnoid space and the bevel can be in the subdural space or epidural space. So what we do is the moment you have a wet tap, advance the needle by another couple of millimeters and then inject the local anesthetic. Generally what we do is we give 2 milligrams of ropivacaine with 20 mics of fentanyl. And once you inject the drug through the Tuohy needle, hold the syringe for a couple of minutes, because the moment if you inject the drug and disconnect the syringe, the CSF and the drug may escape back and you may not get complete analgesia. So what we recommend is the moment you have a dural puncture, introduce the needle by a couple of more millimeter, plug the leak with the stylet, load the drug with ropivacaine, introduce the medication, hold the syringe for a couple of minutes, allow the drug to fix. Now you disconnect the syringe from the epidural Tuohy hub and then thread the catheter. And then subsequently manage as the spinal catheter. Because many a times, the moment you have a wet tap and you introduce the drug intrathecally or introduce the catheter and then inject the drug may not act because the catheter might be partial subdural, partial intrathecal and partial epidural. That's what we follow in our hospital.
What do you think about directing the epidural catheter caudally for managing the labor pain in a better way?
Again, evidence-wise, as we all know, like in the sense when it is a lumbar epidural, even though you think that it might be going caudally, it might not be. If it's a thoracic, because of the curvature at which you're going, yes, there is a higher chance of it going up. So evidence doesn't support that as a sort of beneficial. And one more thing you should think of, if at all it is going down, what about if that patient is going to come up for a cesarean section? You'll have to top it up. And that time you need a level of around sort of T4, T5. So can't that be an issue? So I won't really trouble myself.
In addition, what happens is, if you look at the cauda equina, as it descends down, it just spreads out. So if you thread the catheter caudally, you'll have more segmental sparing. You may not have dense analgesia. So if you want to give a good sacral block in the second stage of labor, give low dose, low concentration, large volume. Generally, we inject about 20 ml of ultra low dose mixture, about 0.05 or 0.0625 bupivacaine with fentanyl, about 20 ml. So low dose, low concentration, large volume, instead of threading the catheter caudally.
What about patient control epidural?
Or if it is towards that end, you can actually think about even a low dose spinal. So that will take you to around sort of 2 to 3 hours.
Have you heard my other query?
No. Can you please ask again?
What about patient controlled epidural analgesia? Is it practiced anywhere?
Yes. Yes. In the UK, actually, initially, that was probably around sort of 10 years back, we started patient controlled epidural analgesia. So they had a sort of a pump, a switch connected to that, and they used to deliver it at the concentrations that I said. 5 ml every 10 minutes was how it was programmed, and that is how they used to use it. So in UK, in most of the places, that is how it is nowadays.
We use it routinely. What we do is we just give about 5 ml every 15 to 20 minutes. So almost about 20 ml per our boluses, patient control boluses, without any background infusion. We don't give background infusion.
What is your opinion, Sunil Pandey? What is your opinion about IV, low dose IV ketamine and drugs like dexmedetomidine for epidural analgesia?
IV ketamine should be condemned because, in fact, I don't know, this ketamine thing was popularized by one Dr. Daftari, who is an obstetrician from Mumbai. And he conducted several workshops in 98, 99, up to 2000. And they invited one of the workshops which was conducted in Hyderabad. Of course, we didn't go because we don't believe in that technique. But the colleague of my friend of mine who went, and he said the dose of ketamine that was necessary, that was required, was almost 1 to 1.5 milligrams with then those days diazepam and then Fortwin. And God knows, it's a very unsafe mixture. Even a low dose ketamine, I must tell you that the laryngeal reflexes, risk of aspiration can be.
About IV dexmedetomidine.
Dexmedetomidine, again, the usage in reported in control studies, but not on a wide spectrum. And personally, I don't recommend. I have no experience also in obstetrics.
Sunil Pandey, one question regarding your topic.
Yes, sir.
What is your experience and this, ECMO in severe ARDS patients, obstetric patients?
In fact, it has been a wonderful intervention since last 5 years. We have been using very good experience, I would say. So the patients who have refractory ARDS or very severe hemodynamic instability, even amniotic fluid embolism, patients have recovered, have been put on ECMO. Yes, the centers are more experienced now. You need to have a multidisciplinary team. Of course, you need a perfusionist, you need a cardiac surgeon, because sometimes the vascular access, especially with the veno arterial ECMO, you need to put a shunt. So yes, outcomes are pretty good, but yes, you need to put cases that are really indicated, not flimsy indications. Refractory ARDS not amenable for your best of ventilation strategies, including prone ventilation. Have been tried.
What is your experience in prone ventilations in obstetric patients?
In fact, it's very good. We have tried prone ventilation. Even pregnant patients, we have tried semi-prone position. Not completely prone position, cannot try it, but many a times lateral position, semi-prone position, they do improve. Now you have devices, bucket devices that are available for prone ventilation in pregnancy, where you have a cord which has a depression, so you can even for students with pregnancy you can put prone, but we don't have that device. But those things are available in the market. Yes.
Is it practical to have them prone or in such positions for more than 15 hours a day? Or
again, what we have done is about 4 to 6 hours maximum, not 15 hours. And those patients who have not improved with prone, we have terminated the pregnancy and then put them on prone.
You have, are you getting cases of severe hemodynamically problematic supraventricular tachycardias in obstetric patients with normal heart?
Yeah, if you look at the type of arrhythmia, the commonest of arrhythmias in pregnancy is SVT with normal heart. And that is because of left atrial dilatation that happens as a physiological change in pregnancy. And many a times it just responds to your adenosine and amiodarone if necessary, but most of the time adenosine suffices. But whenever any type of arrhythmias warrants a blood gas, X-ray, ECG and echo, so that you need to rule out structural heart diseases.
I think the time is getting late. Anything more, Benil?
Yes, sir. If the questions are there, you can go ahead, sir. Don't worry about the time. Because people want to hear from Dr. Sunil Pandya and Dr. Joe.
Yeah, we have covered most of the questions, I think.
Okay.
There is one question I can see in the thing about PIEB, patient patient or control intermittent epidural boluses.
Okay.
Or PIMB, manual boluses. Basically, PIEB again is a type of PCE only, but the pump gives, without any background infusion, intermittent boluses Again, the idea of not giving background infusion is even that low dose background infusion can cause numbness, and it refrains patient from or patient from ambulating. So whenever you're giving intermittent epidural boluses, patient controlled, I think the motor and the sensory is well preserved and the patient or patient can ambulate freely.
Do you get much patients with severe mitral stenosis in final stage of
Quite a lot.
labor?
Quite a lot, yes.
Yeah.
So previously, we have had, in fact, 3 patients that needed perioperative or peripartum cardiac interventions. One was needed emergency balloon valvulotomy, late referrals, and 2 patients needed cardiopulmonary bypass and mitral valve replacement. But yes, good outcome. So if the patient comes a little early, you can always plan percutaneous balloon dilatation and then plan delivery. But suppose if they present very late in labor, then you need to have a cardiac backup in case if the patient goes into refractory pulmonary edema.
So it was a wonderful session, both of the sessions, Dr. Sunil Pandya and Dr. Joe. It was excellent talks, very informative and very useful for the practicing anesthesiologists and the postgraduates, I think.
Before closing, Dr. Sunanda Gupta had some comments. Please unmute Dr. Sunanda Gupta. Praveen. She is the past president, founder president of AOA and the mother of obstetric anesthesia. Please, she had some comments I saw just now.
Okay.
Thank you so much. That was a very informative session. Can I be heard?
Yes, madam. Yes.
Yes. So it was a very good session, both from Joe and Sunil Pandya. And Venkatgiri, I hope you keep on giving us such good webinars. Thank you.
With
so
your
much.
wishes, we should be able to make money.
Thank you. Good night.
And we have Dr. Harsur there. I saw Harsur, Dr. Kameshwara.
Sir, one Dr. Sandeep want to ask some questions. He was asking whether we can allow him. Dr. Sandeep, you can speak now. Unmute and speak.
Hello. Can you hear me?
Yes, please.
Yeah. Now, what you correctly said about oxytocin, methergine, and anaprostine, if it is given unnecessarily, sometimes it causes a vasoconstriction in such a way that even though blood pressure is normal, you are not able to palpate your pulse. And again, no palpation of the pulse with the tachycardia. You unnecessarily land up to start all the supportive thing. So I think this must be taken into care, and very important factor, which you may we recently had gone through this type of case where even though BPO was normal, and in that case, I think you won't have a intra-arterial blood pressure monitoring. Better to shift the patient at places where there is intra-arterial blood pressure monitoring.
Agreed. See, most of the time we don't use intravenous methergine at all. Even the recommendations in PPH is intramuscular methyl-ergometrin. But yes, sometimes it can cause severe peripheral arterial spasm to the extent that patient can go into accelerated hypertensive crisis or coronary spasm, including coronary myocardial infarction and ischemia. So always when it persists, when the tropies are elevated or when the enzymes are elevated, then better to go or transfer the patient to a cardiac center, because generally it's a short lasting coronary spasm. But yes, you need to give vasodilators and ensure hemodynamic stability.
Yeah. And unless you are having a just intra-arterial monitoring, you will not dare to start vasodilator because people think that it's hypotension and tachycardia.
That's true.
Thank you very much.
Thank you. Thank you, Sandeep. There's one more question. Incidence of cardiomyopathy in the postpartum period. Well, you see, most of the cardiomyopathies that we see in the postpartum period are either pre-existing or hypertensive postpartum severe preeclampsia or severe preeclampsia with hypertensive cardiomyopathy, or sometimes peripartum cardiomyopathy can manifest in the postoperative or postpartum period. So any patient who has persistent tachycardia, insidious onset of breathlessness, paroxysmal nocturnal dyspnea, tachypnea, do an echo before shifting or before discharging the patient. And the current COVID, yes, many a times we see even a COVID, there was one question whether you can have COVID positive patient for normal delivery. Yes, certainly you can deliver normally. In fact, COVID positive patient is an indication for epidural because they deliver normally. But yes, a small chunk of COVID positive can have thrombocytopenia. So before you cite epidural in a COVID parturient, COVID positive parturient, check for platelet count. And many a times, fortunately, COVID is mild in pregnant women. But as we have seen, there are mortalities occurring in COVID-19 patients as well. And one of the thing of caution is cytokine storm syndrome is common on 7 to 11 days. And most of the pregnant patients, COVID positive pregnant patients, we discharge them on 3rd or 4th day. So we need to educate all these parturients about signs and symptoms of cytokine storm syndrome, monitor the inflammatory markers on the 5th day, on the 7th day, on the 12th day, the ferritin, D-dimers, LDH, and CRPs. And accordingly, you can flag, alert the patients, not to leave the patient from the radar.
Can you hear me? I can just see one question here, which is what top-up do you give drug volume and concentration to convert a labor epidural to anesthesia for cesarean section? Personally, for me, there is something called a rapid epidural top-up mix. So if I have to do it quickly, this is what I use. And my mix is 10 mils of 2% lignocaine with adrenaline, 10 mils of 0.5% bupivacaine. That's 20 ml in total. I take off 2 ml of that, slowly take in 2 mils of soda bicarb. You have to slowly do it, otherwise it will precipitate. With ropivacaine, it will definitely precipitate. You cannot use it. With bupivacaine, if you slowly take it, it won't precipitate. And then that mix is what I start off with. I tend to give around, even if I have put the epidural in and the epidural was working. Now, the first thing for me is, was the epidural working well or not? So I'll ask the patient, was it working well? And if the patient says that it is working well, except for when she needed a top-up, then that means, okay, I can take that epidural. But even then, I tend to give a test dose. My test dose is not with adrenaline. My test dose is to see whether there's any motor blockade, because your catheter can later on migrate. There are like case reports like that. So what I tend to do is I tend to give maybe 2 ml of this solution, see whether there's any motor blockade, and then you will need between 10 and 15 ml of local anesthetic for getting a level of around T4, T5. So that is what I give, along with 50 to 100 mics of fentanyl, usually 50 mics of fentanyl, epidural. And this will work like a spine. It will work almost like as quickly as a spine.
Dr. Joe, somebody asked about walking epidural. Please.
Yeah, that's what. I did mention it during the talk, like walking epidural with fentanyl. The problem is getting it just up to L1 can be a problem. There usually is slight motor weakness. So asking somebody to walk on it by themselves could be a little bit risky, according to me. So I would maybe ask them, they can actually go to the bathroom, but with somebody accompanying them. But with sufentanil, especially in the US, a lot of studies do say that the motor blockade is much more lesser. The concentration of bupivacaine used is 0.0625, and there are quite a lot of sort of evidence advising the ladies who can go on their own and all. But I'm not sort of, it's not my experience, so I won't be able to comment on that. So I'll get somebody to go with it.
There is a question whether to give the epidural in the operation theater or in the labor theater. Where to give the epidural? Which is the ideal place?
If it's to do the epidural, it can be, again, abroad. It is done in the where the patient is. You go there and do the epidural. It depends upon your setup. Now, if it is with regards to converting it to a cesarean section, I personally would like to give it in the theater, because there has been case reports where, to speed things up, people started it in the labor ward, which is just outside the theater, But unfortunately, that was probably intrathecal, caused a high block and problems because of that. I would never do it. I would get the patient, as soon as the patient touches the theater, I would give a small dose of 2 ml. By the time I shift the patient onto the table, I know whether there's a motor blockade on or off, and I'll start the drug. I'll ask the surgeon to scrub in the meantime, and by the time they're ready, this rapid top-up mix should start working.
There was one question that what is the treatment for pruritus due to epidural narcotics? Is there any specific treatment?
Actually, quite a lot of drugs have been tried, including our conventional antihistamines and all have been tried. But apart from that, the things that have been tried are, one is ondansetron, supposedly against 5-HT3 receptors, it has an action. But among the lot, the recent evidence is pointing towards a small dose of naloxone. When I say a small dose, 10 to 25 micrograms, so very small dose of naloxone. So that is hardly going to do anything, going to reverse your opioid effect. But apparently, and in my experience, 2-3 times at least, quite good effect. So naloxone in a very small dose, 10 to 25 mics. IV.
Dr. Sunil Pandya, there was somebody has asked, you must have read the question, using morphine as the sole analgesic, spinal morphine for labor spinal.
We don't use morphine as a sole analgesic for labor analgesia. Again, as Dr. Joe mentioned rightly, the incidence of pruritus is quite high. And importantly, the nausea and vomiting also is almost up to the 30-40%. So at one end, you're trying to relieve the pain. At the other end, you're giving pruritus and nausea, vomiting, which are equally distressing for the participant. So we don't use sole morphine. And importantly, the morphine also acts for about 2 to 3 hours, and sometimes you may have to repeat epidural. So whenever we are giving spinal analgesia for a participant for labor, as a part of labor analgesia for this thing, we always counsel them, and within 1 to 2 hours, we put an epidural also. Because we have seen that sometimes primary gravida, the second stage of labor, sometimes lasts for about 2 hours, 2.5 hours, or 3 hours. Generally, is what our protocol is. We give trial for 3 hours. At the end, if they don't progress, then we do cesarean section, and you end up again giving one more spinal. So rather than that, once the patient is comfortable with spinal, after some time, you set an epidural so that in case if the mother requests or requires cesarean section, it can easily top it up.
There was a question about a low molecular weight for a epidural patch.
So,
what is that? Low molecular dextran. Low molecular dextran for.
Dextran, yes, it has been used in olden days. Archaic. It is archaic. We don't recommend now. The standard recommendation for post-dural puncture headache, if it is severe, if the mother is not carrying her baby, if PDPH is severe, then blood patch is the gold standard. But no dextran doesn't work. Saline has been used, but it has just temporary relief. But the only definitive treatment is epidural blood patch.
One more question is the incidence of peripartum cardiomyopathy. Is it too high, and what is your experience? Somebody was.
I would say incidence of peripartum cardiomyopathy is increasing. I would say, especially Tokotsuba cardiomyopathy, the dilated cardiomyopathy, the peripartum cardiomyopathy. It's a bundle of different types of cardiovascular disorders, hypertensive cardiomyopathies. But we do here probably in a year we get about 6 to 7 cases of pure peripartum cardiomyopathies. Otherwise, most of them either they are dilated cardiomyopathies or they are part of hypertensive cardiomyopathy spectrum, and they recover. Hypertensive cardiomyopathy they recover quite promptly or within 1 week. But PPCMs they progress. It's a progressive disease, and most of them they recover mildly, or sometimes small chunk may not recover, and they subsequent pregnancies they may present with failure again. So if you ask me the incidence about say 5 per 7,000 is what 5 to 7 to 8,000. Yes, not many cases.
Opinion on use of chlorprocaine for conversion of labor epidural to surgical anesthesia.
Again, chloroprocaine has been used quite like last 4-5 years it has been used because of its immediate rapid onset of action and dense analgesia and a very short lasting like just about 15-20 minutes. I don't recommend because it's a para-amino benzoic acid derivative and the incidence of allergic phenomena is quite high with chlorprocaine compared to amino-amide local anesthetics. And importantly, the rapid mixture that we recommend in our hospital is 2% lignocaine, 8 ml, 1 ml of bicarb, 1 ml of fentanyl, 10 ml given over incrementally and load the same mixture again and give another 5 to 7 ml till you get a block about D4 and D5. The onset of analgesia is within 5 to 7 minutes. Within 5 to 7 minutes. So chlorprocaine hardly is needed. But many a times people have used to test the epidural catheter. They just give chlorprocaine and within 3 to 4 minutes you get onset of analgesia. That means, okay, your catheter is working. But again, PABA is a nuisance for us because of allergic tendency and importantly, methemoglobinemia also, if the dosage is high.
Sir, somebody asked about the use of buprenorphine on low spinal.
See, any any narcotic that is that cannot be reversed should not be used. So buprenorphine is again a partial agonist, antagonist, and we don't have any antidote. And respiratory depression is common, so we don't use buprenorphine. Even though there have been several cases in the past where buprenorphine has been used intrathecally, epidurally, but we don't recommend buprenorphine, neither butorphanol, neither any of those partial agonist, antagonists. So fentanyl, yes. Buprenorphine, morphine, yes, and sufentanil, we had availability for a brief time, about a year or so, but these are the pure new agonists that can be recommended, that can be used.
And somebody wants to know about your LA conversion to LSCS. You have already answered in the chat box. Can you please repeat? That will be good.
As I said, what Dr. Joe mentioned is his regime, but what we do is we use lignocaine with adrenaline, 8 ml. Take 1 ml of 7.5% bicarb and take 1 ml of fentanyl undiluted. There is 50 max of fentanyl. So total 10 ml, give incrementally 3 ml over 3 to 5 minutes. And generally this gives a block till D10 and load the same mixture, 8 ml of 2% lignocaine with adrenaline, 1 ml of fentanyl and 1 ml of bicarb. And generally total 16 to 17 ml suffices. You get a decent block about D4 and D5. The idea of not using bupivacaine with us is catheters can always migrate and we have seen catheter migration occurring after the 7th top up, 9th top up, 11th top up. It can migrate intrathecally, it can migrate intravenously. And inadvertent intravenous migration and bupivacaine toxicity, it is very difficult to reverse. So it is easier to treat lignocaine toxicity than bupivacaine toxicity. And that is the reason that we don't use bupivacaine for epidural top up for cesarean sections. We always use lignocaine with adrenaline, bicarb and fentanyl.
Okay. Any relevance of giving intramural prostadine to intramuscular in preventing systemic effects of prostadine?
See, basically, whenever you're giving intramuscular carboprost tromethamine, it gets absorbed systemically and then acts on the uterus. So when you're giving intramural, especially when you have atonic PPH, apparently it reaches faster. So definitely intramural has a role, but importantly, the precaution that you have to take is aspirate and give. The surgeons by default, they don't have habit of aspiration before injection. So they just inject, and if it goes intravenously, then I have seen on-table bronchospasm, severe bronchospastic crisis happening. So you have to be careful that they aspirate and see that they aspirate doubly and then they inject intramurally. It acts faster, definitely it acts faster.
Opinion on fentanyl alone, epidural?
Dr. Joe, you want to answer?
Yeah, if you're putting an epidural, you might as well make it work, isn't it? So rather than giving a big dose, because rather than giving, if you're thinking of that only working, you have to give quite a big dose. Why try something unnecessarily when you can combine the effects of both? We are supposed to be balanced anesthetists, so let's balance things and give a small dose of each. So I don't see any reason why I should give only fentanyl. It will cause more pruritus. It will cause more respiratory depression, because at the end of it, this will get absorbed. A part of part of the reasons how an intrathecal non-epidural opioid works is systemic absorption. Yes, there is the working in the spinal horn and things like that, and all is there. But part of it is systemically absorbed as well. So if you give a very high dose, it can cause sedation.
There is one tricky question, actually practical question. What to do if panicky surgeon insists on unnecessary use of methotrexate?
Placebo, give saline. We often do that.
That is the best thing. Other you open an ampoule of methotrexate, don't give that, give something else. And sometimes they ask us if given that.
Having said
Excuse me,
that,
I would like to answer that question.
having said that,
Dr. Pandey,
yes.
it was an excellent presentation. I'm Dr. Ramchandra Reddy, anesthesiologist, retired and living in US now. I was working in SVS Medical College and Kurnool Medical College. I was in Saudi for 9 years. And I was there in Saudi in a maternity hospital 4 years. And every week we used to get placenta increta, placenta previa, and pregnancy-induced hypertension and all. We had so much. And any time, if the obstetrician wants methergine, I always say that I have given, but I never give methergine. I always tell lies to them. Because that's why I typed, I told them methergine is the enemy #1 for anesthetist. And in fact, when I was working in Kurnool Medical College, some of the postgraduates, they gave methergine to some patients who had mitral stenosis, and the patient died on the table.
Yeah. So what happens is generally, that's where you open communication with the surgeon is of paramount importance. So nowadays with WhatsApp and mobiles, hardly anybody or any of our colleagues, they peep into the surgical field. But truly, if the surgeon is panicky and struggling with the atonic uterus, then you need to address it. You need to address it, and that you need to do what is good for the patient. So what we do is we have an open liaison. Yes, there are some surgeons who have a routine habit of giving it's not relaxing, but you visibly see the uterus and you yourself will know that yes, oxytocin is not working. Go and give something else. So you should not delay, because we have seen atonic PPH migrating to major massive hemorrhage, atonic PPH going in, landing up with cesarean hysterectomies. So appropriate judicious use of uterotonic is what is warranted, and you need to have open communication, and you yourself can inspect, look at the tone, how the uterus is retracted.
Yeah.
That is very important.
So what about the local?
And I would like to ask you one thing. Are they using uterine embolization instead of doing cesarean hysterectomies?
So what we routinely do is that we have had almost 78 cases of percutaneous where we use routinely internal iliac balloon occlusion catheters doing cesarean hysterectomy. The balloon, deliver the baby, do a classical cesarean section, not a lower segment, because lower segment is placenta is adherent. Do a classical upper segment cesarean section, deliver the baby. Once the baby is out, inflate the balloons, and generally we proceed with hysterectomy with a total percutaneous. Suppose if it's a patchy or focal, generally it's either the placenta is left behind, or sometimes it comes off within after some time. But occlusion catheters, they work quite well.
Because when we were working in Saudi, we didn't have that facility. And I was told that in the Brigham Women and Children Hospital, the incidence of embolization is very much high.
Yeah. So suppose if despite the advantage of balloon occlusion catheter is if the bleeding still continues, you shift the patient back to cath lab and balloon sheets are already there. You insert the catheter again and embolize the bleeding vessels. Yes. But occlusion catheters are, if you ask me, technique of choice. But we have had almost about 5% incidence of common iliac thrombosis, which was picked up as a protocol, and then we had to use Fogarty to expel the thrombus. But that is one side effect. But yes, we could avoid major hemorrhage, because we have seen adherent placentas, percutaneous initially without iliac catheters, or if you don't proceed with rapid hysterectomy, patient losing almost about 15-20 liters of blood and requiring multiple units of transfusion. So you have to, one technique doesn't suit all the patients. So if there is a percreta, then balloon occlusion catheters is very useful. Sometimes some of the centers, like in maternity hospital, my colleague works there, they use manual compression of aorta. When they are, once the baby is delivered, they manually compress aorta and the surgeon proceeds with hysterectomy. That also minimizes the blood loss. So multiple techniques are there. You need to see what is good in your setup, in your hospital, and for the patient. It has to be tailor-made for every patient.
And in my experience in a maternity hospital in Saudi Arabia for 4 years, we used to get this, PPH and even this placenta previa cases. And we used to have, but our blood bank was very good. We had all the facilities. So there was no mortality totally. And every week we used to have such cases, at least. And the gravida also. We have anesthetized 22nd gravida, 24th gravida also.
Ayyo.
God.
And 10th gravida 10 is very, very common.
What about
And
bleeding in those patients?
Heavy bleeding. So they resort to cesarean hysterectomy only, because there were 10 MRCOGs, they were shivering to work. Because in United Kingdom, they don't have so many cases, such gravidas. And I feel such cases come in India in a government hospital, many people will die. Thank you, Dr. Venkatagiri, for conducting this very, very nice.
Thank you, sir.
Somebody
Thank you.
asked about the LA toxicity in case of prolonged labor.
LA toxicity, there was a question in epidurals. Dr. Madhuri Lankur Sarika has asked that question. Yeah.
So you want
LA toxicity.
Yeah. So basically, if it's, you can hear me, isn't it?
Yeah.
Yeah. With LA toxicity, wherever you're doing epidurals, I would say that you have to have intralipid. Okay, that has to be there. You have to stick the poster so that nobody's confused about how much to give, because it might be a postgraduate who's doing the procedure. There's no time to think about and call the consultant and get the things. So if there is a if you're suspecting it neurologically, or if there is a cardiovascular collapse, this has to be the thing that has to be given. So it will be, that is what I would do. I'm never, again, touch wood, never had a case of LA toxicity, but we have intralipid available in our hospital, ready to be used.
Is there role for IM methergine? Somebody was asking. We are telling no IV methergine, any IM methergine. Intramuscular.
Definitely, when you have postpartum hemorrhage, the drugs of choice are oxytocin infusion, 5 to 10 units per hour. If it doesn't work, then you need to give carboprostopamine intramuscularly. You can give up to 2 milligrams over every 10 minutes. And IM methergine, definitely you can give up to 0.6 milligrams over 30 minutes. I mean, every 30 minutes you can give 0.2 milligrams intramuscularly. So 1.5 hours you can give up to 3 doses. So beyond up to that time, you don't have to wait. A decision for hysterectomy has to be made early. See, majority of the time, patients who die because of atonic PPH or this thing, the decision to conserve the uterus is too much. They try to do all sorts of interventions, but when the uterus doesn't retract despite at least 2 or 3 doses of carboprost or 1 or 2 doses of methyl ergometrin, then you need to take a call whether you go for compression sutures or internal iliac ligation, because many times the obstetrician, they do uterine artery ligation. But I must tell you that uterine artery ligation doesn't help much, probably 10, 15, 20%, not much. So internal iliac ligation, yes, you are cutting off at least 70 to 80% of blood supply to the uterus. But have a low threshold to do cesarean hysterectomy if it is at least if she has one living issue, and do not delay, because many times the decision to delay hysterectomy is the major cause of mortality and severe morbidity. Like whenever you have total spinal or high spinal or profound hypotension, the decision to delay in administration of adrenaline is the cause of morbidity and mortality. So have a low threshold to use adrenaline early if there is an unresponsive patient with hypotension following total spinal, high spinal, or even last. Adrenaline should be used early. Similarly, decision for hysterectomy also should be made early rather than reserving towards the end.
Yes, and as Dr. Sunil was saying, that before they go into DIC, you should have started. Once they go into DIC, it is all like the uterus is open, relaxed, that's it. So as he rightly said, the decision to do a cesarean hysterectomy, you might have to contribute. You might have to give them that idea. Okay, that's one thing. The second thing is for the postgraduate residents, always try to see what is across the screen. Try to see the uterus. Try to see those rugosities happening on the uterus. That is something that you have to keep on looking. As soon as the baby is out and the placenta is out, you can see the rugosities appearing. So look and learn how it is.
And last question, my own question. Any experience of Panikkar cannula for this lady?
Any?
Panikkar cannula, you must have heard.
Dr. Panikkar didn't join today.
In fact, I met him at Chennai, if I remember, yes.
Chennai, that conference he was there, yes.
I don't have much of experience, honestly, Dr. Venkatgiri, but he claims that it has helped in all the patients. Basically, it's a vacuum-based therapy where you use cannula and put a vacuum and it just sucks in the uterine cavity and minimizes the blood loss. But
I have also seen and used that gynecologist using that. See, when there is severe bleeding, what he says that both the whole uterus collapses and the walls adhere to each other, and there is no bleeding. There is a principle, and 20-30 minutes.
Does the same thing from outside.
Is what it says, and it has helped because in periphery and all. Now I am seeing it now routinely, and there is a bleeding when doubt gynecologist. I don't know whether it is overuse, but they do it.
Dr. Joe must be knowing Dr. Paili, VP Paili.
Yes, Dr. Paili, yeah. He was my teacher.
He is an authority, and I have learned that we did a workshop on adherent placenta at Hyderabad Fernandez Hospital, our hospital. And this was a case of percreta, which was being telecasted live as a part of, because it was a live workshop. And the patient bled 12 liters in 3 minutes. 12 liters in 3 minutes, and patient almost had asystole. So push adrenaline, and I told Dr. Paili, we are going to lose her. I said, don't worry, Sunil. Very cool. And he just put a clamp on the aorta.
That's his technique. Probably it's known with him. Obstetrician putting a cannula to the aorta. In this region, he's the only person who does that.
Absolutely. So that probably that with that case, I kept in mind, and subsequently we have introduced that perimortem cesarean section guideline. If it is a accreta or a percreta, have a vascular clamp, because it is you can easily put it. Just have to palpate, lift the uterus, and put it infrarenally below the kidneys, and it works wonders. At least it is a life-saving procedure, intervention. That patient survived, of course.
Thank you. I think
thank you,
the questions are over, and we had a wonderful
questions
session.
From Dr. Govamar? Govan sir, any questions from you?
I think Praveen can unmute everybody. Anybody having any doubt can ask. Kameshwara, I think, has left, and others, if anybody, they can.
Yeah, sir, they can unmute themselves.
Yeah.
Govan sir.
From my side, it was a wonderful session, very informative, I think, for the not only for the practicing anesthesiologists, for all the postgraduates, even the postgraduate teachers. Very informative from both the speakers, Dr. Sunil Pandya and Dr. Joe. I thank them, and wish you all a very good night.
Thank you very much, sir. Again, ISA Kerala and Dr. Venkatgiri for giving me this opportunity. Thank you very much.
For the vote of thanks, Dr.
Praveen, post that our CME poster when Binil is proposing vote of thanks. That our conference poster.
Binil, vote of thanks.
Yeah.
First of all, I thank Dr. Sunil Pandya, Director of Century Super Specialty Hospital, Hyderabad, for joining us today evening. If I borrow the words of my teacher, Dr. Suresh Nair, excellent presentation, sir, as usual. Always a treat to listen to you. That is the words he has written in the chat box. So thank you, sir, for joining us today evening for the excellent presentation. I extend my sincere thanks to Dr. Joe Chirayathe, who is our own member working in Amala Medical College, for his wonderful presentation on labor analgesia. Of course, this topic is very interesting for the PG students, and it's a long question for PG students. Thank you, sir, for the excellent presentation. I extend my sincere thanks to our moderators, Dr. Madhusudan Upadhyaya and Dr. Gopkumar. Thank you, sirs, for joining us today evening. I extend my sincere thanks to Dr. Venkatagiri, President-elect ISA National, for organizing the webinar for today evening. I extend my sincere thanks to Dr. Nasser, our state president, for helping me to organize the webinar for today evening. I can't remember Mr. Praveen and Praveen Udupa for helping me for arranging the webinar for the technical aspects. Thank you, Praveen. Then I thank all the participants for joining us today evening. Almost 370 participants joined today evening. Around 270 in Zoom, and others were in the YouTube. Thank you all for joining us today evening. And it was a wonderful session. Thank you all. And I just want to remind you all that we will be conducting our ISA WebCon Kerala 2020 on 1st of November. So the Kerala Piravi Day, 1st of November will be our conference day, and we will be starting by 8:45 and will finish by 5 p.m. So I request all our participants to join ISA WebCon Kerala 2020 on 1st of November 2020. The registrations will be free. Please do register for ISA WebCon 2020 Kerala. Thank you.
Thank you. Thank you very much.
Giri sir, anything else to do?
Nothing. Thank you everybody for joining.
Many of our national leaders joined today. I have seen Dr. Chakra Rao, Dr. Kameshwar Rao, Dr. Kiran Gera. Many of our leaders joined today. Thank you all for joining us today evening. And Tamil Nadu Secretary Dr. Krubagaran and Tamil Nadu President Dr. Sudarshan joined today, and many of our Kerala leaders also joined.
Our regular
joined today.
Our regular Dr. Chittara, Dr. Hiremat, they are regular participants. They are also there, and we wish them all a happy Onam. Invite them from Onasadhya.
Thank you, sir, from Rajasthan.
Chittara sir is there, Rajasthan.
Yes, sir, from Rajasthan. Regularly, I am visiting your. Yes, thank you. Very nice.
So,
thank you, Dr.
Okay, thank you all. Good night.
Thank you all. Good night.
Thank you.
Thank you.
Thank you.
Okay, madam. Thank you. Sir, that is my madam's voice.
Good night, Venkatagiri.
My HOD. Good night.
Good night. Good night.
Yeah.